Thank you very much. So, the last people, or a few people still coming in. My name is Thorsten Böker. I'm with Ingrid's detachment course, not from the first day, but at least for the last 35 years. So we have seen quite a bit of young and eager colleagues like you who want to discuss the advantages and disadvantages of various techniques for retinal detachment surgery. And this course just basically lives with all the discussion we would like you to be involved with. So whenever there's a question, raise your hand, just ask us, and we are trying to answer everything, and we want to be thought-provoking. And for a short note, please, Ingrid, if you would say hello to everybody else.
Hello to the audience. I'm happy that you are around. I hope we don't disappoint you. As Thorsten already mentioned, we are here to answer your question. Why? Because by your questions we learn. And I would like to implant something in your brain and your daily work. Always question, scrutinize when you're doing surgery. Why are you doing this? I'll just tell you very shortly. I'm since eternity already in detachment surgery, and the most important thing was when I started to take care of the fluid. We took care of the symptoms, not of the cause. Finally, by smart people, we found out that you have to look for the break. And that is the clue of this teaching course. We want to teach you to think, not to think of surgery in the first rate, to think, what should I not do? What is the cause I want to treat? And we give you guidelines how to find the break. And if you find the break, then you can treat the cause of the detachment, the hole, which is less than 1 millimeter, smaller than a disc. So we try to introduce you to minimal surgery without drainage. And to start how to find the break, the first is Thorsten. You heard already. Thorsten now, the first speech that will stay in time. Thank you. I hope you're not disappointed of the course.
Okay, I have nothing to declare. It's not a surgery that's involved with a lot of money. Why is finding all of the breaks preoperatively mandatory in retinal detachment, and how to do it? Basically, if you look at the definition of a rhegmatogenous detachment, rhegma is the ancient Greek word for a break, a tear. So the pathogenesis of detachment involves full thickness retinal breaks. There's always the discussion about vitreous traction, but if you only have vitreous traction and no break, you will never have a rhegmatogenous detachment. So we are talking about rhegmatogenal detachments. And of course, then liquefied vitreous, or after vitrectomy, the fluid of the vitreous cavity will come into the subretinal space, and that really creates the retinal detachment. But without a break, no rhegmatogenous detachments. If you put it the other way around, if you don't close the break or all the breaks, you can't cure a retinal detachment. So that's very simple, very logical. So if you know that if you have a break and you wait long enough, you will have a detachment starting up to the aura, and if you wait longer time, then you will have a larger retinal detachment, but still, all the fluid that accumulates in the subretinal space comes through the retinal tear. So if you close that break, there's a permanent fluid transport via the pigment epithelium and the choroid out of the eye, then the subretinal fluid will disappear. So the only thing you have to do is close the break. What do you have to do? You have to take a complete history, like in all your cases. You do a complete eye exam. You want to know the cornea, the iris, the lens, is there artificial lens, is there after cataract, and are there corneal opacities? And then you have to search for all the breaks. If you treat a rhegmatogenous detachment, you have to find all the breaks and you have to close them all. And if you know them ahead of surgery, you will be much more successful, regardless whether you do a pneumatic retinopexy, a vitrectomy, or, as we propose, a non-drainage buccal. Contact lens examinations mainly are done, of course, at the patient sitting at the slit lamp. And the indirect you should be very familiar with, and indentation in the patient lying down, because in the OR, the patient is lying down. If you have examined the patient only sitting up with a contact lens, and he's lying down on the table, you have the speculum and you have dilated the pupil, it looks different. And if you have not really studied the patient with a binocular indirect before, you will run into problems. Scleral indentation is very, very helpful because it brings the ora serrata into your view. And by just changing the angle of illumination and opening small breaks with the indentation, you are much more thorough and much more effective in finding all the breaks. So get familiar with the examination under indentation. And you actually, if necessary, can combine contact lens examination with indentation as well. You know, for the 3-mirror Goldman contact lens, there's even a addition that you can make it more easily. In terms of documentation, which basically will be the next talk, please keep in mind that on our drawings, we convert a 3-dimensional structure into a 2-dimensional presentation. And there are some distortions. And the one we use for the purpose of rhegmatogenous detachment surgery has the least distortions. So for our purpose, and that will be stressed throughout the course, the optic nerve is in the center of our drawing. Why? Because the fluid in the subretinal space moves around the optic disc, because the retina is fixed at the ora and the retina is fixed at the optic disc. And then we can see the optic disc in the center. We see the ciliary body, ora serrata, and the equator. And basically, from that on, if you put in terms of fluid dynamics the optic nerve in the center of your drawing, then it's easily to understand and follow the rules that Ingrid pointed out in her books. So in summary, rhegmatogenous detachment, rhegma is the Greek word for tear or break. So you need to find and have a break. Only vitreostraction doesn't do the job. So any open break will allow the fluid to enter the subretinal space. If you leave any break open, the fluid will re-enter. So thorough preoperative examination that you are free in choosing the operation method you like. And that is indirect binocular and contact lens exam in the patient upright and in the patient lying down. If you do that, you are much more successful, even though it might be modern now to see, well, there's retinal detachment, let's do a vitrectomy, we'll find the holes during surgery. That's not the best approach. Better you know what you are up to in your surgery, regardless of a buccal, a vitrectomy, a pneumatic. Please, please be thorough and examine the patient preoperatively so you know exactly what you are dealing with. Thank you very much. Any questions? Anybody disturbed with the optic nerve in the center of the drawing? I should see 50 hands up in the air. No. So please, it's not that the optic nerve is in the center, but the fluid moves around the optic disc. And therefore, in terms of finding the break, you have to orientate you to the optic nerve. Please keep that in mind. And you will see throughout the course what's the important. So, Stefan, please continue with the documentation. Stefan Mennel is a very old friend of us who is now the chief of the University Eye Clinic in Feldkirch, Austria. And I think you are with us for 35 years as well.
Yes.
So, and he is a very experienced surgeon in minimal non-drainage surgery.
Dear Professor Kreisig, dear Thorsten, now the topic is documentation and detailed fundus drawing. We heard from Thorsten Böker what is necessary, what we have to look about, what we have to see, and now we want to make our template. There are many different templates, as Thorsten already pointed out. As you see, 3 different here, but nevertheless, as the retina is fixed at the disc, always look here, go for the center, and start with the center for the disc. We have many possibilities. We have fundus drawings and fundus image. Today we have a wide field fundus pictures, and they look very great and good. But nevertheless, the main findings in the periphery, they are not there. Therefore, they are not successful for us. We need drawings, and we can draw manual or digitally. We usually, in our cases and our patients, we go for a manual drawing. But nevertheless, for our presentation and the broker from Professor Kreisig, you see digital drawing, and they are also very helpful to know how to make my hand drawing for each case we have to look for. And first, the indirect ophthalmoscopy is helpful looking for the borders of the retinal detachment. And when we take, you already got a template when you at the entrance of the hall, and you can see there the center is the disc, and on the back side there are also drawings. These are helpful if patients after surgery to see the follow-up if there was subretinal fluid and if the retina is attached on the first or second day. This is very helpful for the following days after surgery has been performed. And in our clinic, this is our template. First, there is the name that has been the date, remarks if the patient is pseudophakic, or if there hemorrhage, and additional remarks are placed here, and the physician. It's very important also to write down who has done it, that afterwards we can discuss with the young person in training, what have you seen, what is missing, after surgery to discuss once more, add something, add lattice, add a retinal break that couldn't be seen before. And if you had studied the patient in the laying position, yes, you go for the border of the retinal detachment in dark blue line and look for the break, also in dark blue color. After control with contact lens, as already pointed out, you go for more detail. And you know in the periphery the details you have to find out. And if you look to these both pictures, these are not photographies. No, it's drawings. And 20, 30 years ago, they were specialists in the clinics where they made the drawing. It's these pictures are hand drawings, and you see on the left side the retinal detachment. On the right side, you see the retinal break. It only could be seen by contact lens and indentation. Otherwise, it couldn't be seen. Therefore, also indentation is very helpful looking for retinal breaks. And in this case, there was a retinal break. Precise looking to the periphery could show lattice degeneration. You can see presented at this area, and these small blue dots, they present the line of the detached vitreous, which is also very helpful. Why? The vitreous is detached on the center up to this line, because breaks typically, and these areas, you have to look very carefully if there are maybe further breaks at this retinal detachment. And looking for the colors you use in your daily work. Red is the color of attached retina. The blue is the detached retina. In green is everything prior, anterior to the retina, maybe blood or fibrous tissue. And yellow is subretinal alterations like RPE, atrophy, or laser or cryoscars. And brown represents buckles. As you see here, a demarcation line, the retinal break, and the pre-retinal tissue. Going to another case, you see here in red color the attached retina. The retinal break within the tear, it's a dark red. It represents the choroid. So, and the blue line around, you can see the flap that is elevated and is in blue color. The yellow color represents the scar of the laser treatment or the cryo treatment. In the case of a total retinal detachment, you see here the insertion line with the blue dots of the vitreous, where the most alterations, the most traction is at that moment. You have the lattice degeneration presented here with the retinal break within lattice, the horseshoe tear within dark red within the break, and this is presented here, once again, lattice, the vitreous space, and these small dots you see here without blue color, these small dots represent small retinal hemorrhages. These are no retinal breaks that not been have to treat it. And if you look to the book 1 and 2, you have many such pictures and fundus drawings. They are helpful, and you can see how these things have to be prepared and which colors have to be used. So preoperative, detailed and precise examination and the documentation is necessary, because only if you find the breaks and only if you treat these retinal breaks, you are successful. Thank you very much.
Any questions? Maybe one question. Is it always easy to find the borders of the detachment, or how would you define the border of the detachment? What do you do to find it? Oh, you will talk about it. So, you can listen then. So the next person, Ingrid, please come up to the front. Does not need to be introduced. You are the hallmark of non-drainage buckling surgery. And of course, you have nothing to declare except for retinal detachment surgery.
Now let me see to move.
Yeah. You move it.
Yeah.
Genau.
All right. Now let's go to the cause of the detachment. We talked about the fluid. We want to get rid of it, but we get rid of it only if we find and define the cause. Now I want to put something in your mind. When we treat the detachment, we actually treat the symptom, the appearance. But what do we want to treat? We want to treat the cause. And the cause is a retinal break. And if you want to treat the retinal break, simultaneously it implies to do minimal segmental buckling limited to the area of the break. And now people who are doing other types of surgery and cerclage, they will say, and I take your questions already, but if there are many breaks, am I not better if I do a cerclage? Now, I tell you the results of a very careful study of 1,000 preoperative drawings before doing limited buckling. Keep in mind, every second detachment in 50%, listen, there's only one break. In 30%, there are 2 breaks. And in 20% more than 2 breaks. And now you will say, all right, now I have to do a cerclage. We can help you on the basis of 1,000 detachments we have analyzed. The additional breaks, up to several breaks, are within 1 quadrant of the primary break. So now we concentrate on the primary break to find it. As Thorsten mentioned already, and Stefan Menne, you test at first, you examine your patient being in the conditions for surgery, in lying conditions on a stretcher. Why? Because the retina reacts logical. And I tell you some hints how to better find the break. Determine the borders of the detachment, because the border of the detachment tells you where to look for the break. And how to find the real borders of a detachment. You don't find the real borders if a patient sits at the slit lamp, and if he lies on his back, turn the head to the right, turn the head to the left. Okay. And then put your patient to the slit lamp and make, as Thorsten mentioned already, and Stefan, a very precise drawing. Why is this important? You want to do minimal, most atraumatic surgery. What is atraumatic surgery? not to indent very much because you don't find the break, not to do diagnostic cryo because you don't find the break. If you have a good drawing, a guideline, a line, a map for Boy Scouts or Girl Scouts, Scouts are here, to find the break, then you can precisely depress and find your break. In presence of a contact lens, you can also make this indentation we mentioned earlier. Very careful. If you press too much, the patient squeezes and we have gravity, the conjugal lens ends on the floor. Very careful. And important, make a good drawing. Now we are going towards a detachment. The type of the detachment is defined by its extent. It depends, is the break superior or inferior? You know already. Then you have a different type of detachment. And when there is a certain amount of fluid around the break, we have gravity on the Earth, the fluid tries to descend, and it's stopped. Where is the retina stopped to detach? Where is the physiological attachment? At the disc and at the aura serrata. However, if you have done very much so-called prophylactic treatments, which might not have been needed even, I'm doubtful, I'm questioning, the scar stops progression of fluid and disturbs the contour which helps you to find the break. And in addition, if there is a buckle, the fluid cannot further progress. Now, let's go into clinical detail. Here you have the horseshoe tear, and I want to go back.
Exactly.
With the pointer, it's difficult. I think I do it without. Here, at first, the fluid develops around the tear, where there is traction at the operculum. The fluid amount gets larger and larger. It descends, crosses 6 o'clock, and gets up on the second line as high as on the first side where the primary break is. The retina reacts logical. You just have to understand this logic to be a minimal surgeon. Now, rule number 1. Linkoff defined it together with Gieser, and I helped at the end with the 4th rule, but these are the 4 Linkoff rules. Rule number 1. Superior temporal or nasal detachment in 98%, let's say in 100%. The primary break lies within 1.5 clock hour beneath the higher border of a detachment. Isn't that marvelous? And in 50%, there's only one break. So the contour really helps you. Now, another contour. There is a break at 12 o'clock. Be critical. I'm sure you are critical. It is not exactly at 12 o'clock, do we admit? It's a little bit towards 11 o'clock, and the retina reacts logical. It is at the side of 7 o'clock more inferiorly. So the contour tells you where the break is off center a little bit towards 11 o'clock. And by the way, by the time this detachment gets total. What does this imply? Linkoff rule number 2. Total or superior detachments that cross the 12 o'clock meridian in 93% in more than 9 of 10 cases. The primary break is at 12 o'clock or in a triangle, the apex of which is at the aura serrata and the sides of which extend 1.5 clock hour to either side of 12 o'clock. Now look, the more posterior it is, the hole, the more it is off the center of 12 o'clock. The retina reacts logic. You just have to understand the logic and your life gets easier. Now remember, you have there the book, the fundus drawing 1 and 2. They have a break superiorly located. The detachment has a convex contour. However, when the break is superiorly located, it gets subsequently bullous. Now, we have an inferior detachment. Convex contour, yes, there is a break. But it's not bullous. Where should be the brake? The retina reacts logical. You just have to understand the logic. And what's important? What did you learn? Contour. How is the contour? It's asymmetric. Where the contour is higher on this side, the hole should be, yes, it is 7, a quarter of 7. And rule number 3, inferior detachments which are not bullous, in 95%, in more than 9 of 10 cases, the higher border is important to look at of the detachment, indicates on which side of the disc an inferior brake is located. Isn't that marvelous? If you understand the logic, surgery, finding the brake and treating only the brake suddenly is so easy. You just have to understand the logic. And we human beings, we have logic. Let's continue. Now, what is this? An inferior detachment. Yes, you agree. But what is typical for an inferior detachment? It is not bullous. This is bullous. What do the smart people think when an inferior detachment is bullous? Cannot someone help me? Thorsten?
There should be a brake above the horizontal.
All right, let's check. We didn't find it. What do you do when I told you in the beginning? Tilt the patient to the right and to the left to know the real borders. Tilt the patient to 3 o'clock, you get what is there. The border remains the same. If you move the patient to the 9 o'clock, suddenly a sinus is opening. And there is a small break. He is right. The hole is above the horizontal. It is 9:15. Now, conclusion.
Would indentation help as well?
Yeah, if you do indentation and the patient doesn't squeeze and your condylar lens stand on the floor, you could have found it, but I hope everybody will do it after the course. Would be great. Now, rule number 4. Inferior bullous detachment. Bullous, I'm saying. Inferior bullae in a rhegmatogenous detachment originate from a superior brake. It's not the retinal logic. If you see a detachment, you don't have to think. You just have to follow the logic of the retina, and then you will find the brake. Now, what is characteristic of a rhegmatogenous detachment? Because there is something very similar. Who will know it? I help you. Schisis, convex contours, bullous sometimes. What is typical for a rhegmatogenous detachment? As I pointed out, convex contours, convex surfaces. Finally, extend from the aura to the disc. And the dependent shape is in relation to the most superior brake. And the detachment is progressive. The more progressive is the hole is superiorly located. Remember, gravity causes to progress by the fluid. And there are 3 types of detachments. And all the slides we are showing you here are in this book, and I was informed by Thorsten. This book is sold out, is translated in Japanese, Russian, Chinese, English, and Spanish. However, in English version, if you like to have all these figures, it is available as e-book. And these are the rules, and the Congress was so generous to copy the rules. We made them in DIN A4 that you can put it in your doctor pocket, and if you don't know it by heart, you pull the chart and you look, reoperation, primary operation, and think of the logic, and you will survive doing detachments at a minimum input. Thank you. Questions? Please.
Go to the microphone.
Oh, the ladies help you to bring the microscope. That is agreed.
Thank you, Doctor, for your great presentation. Actually, I find difficulty in understanding rule number 4. How can you explain it logically? How can superior brake causing inferior bullous detachment by logic principle and understanding to the other rules?
I think if the hole is superior, there is much more fluid which can move down, and then it is the gravity which makes that it finally becomes bullous. He has another question.
Yeah, but why the superior retina doesn't detach before reaching the inferior?
What?
Again, the inferior retina, of course, will detach in all cases, as long as there's a break above. The problem is if you have a bullous detachment is never explained by an inferior break. So even if you find an inferior break and you only close it, you have a 5% chance to cure the detachment. A bullous detachment needs a break above the horizontal.
I hope we explained it.
Yeah,
and now we get support from another continent.
Yes, you're asking why it's bullous when it's a superior. It's because gravity makes it bullous.
Yeah.
When the break is inferior, it has to fight. The fluid fights against gravity to get superior, so it's never bullous.
That's a very smart explanation.
Dr. Krasik, just one
Thank you.
comment.
Let's continue.
Just one comment.
We are running in time.
Yeah, so the question is that why the superior retina also did not get
Exactly.
detached when the retina inferiorly got detached. The reason is that when you have a very small break, sometimes the fluid slowly trickles and it goes along the aura and then accumulates inferiorly before the superior retina also gets detached in these cases. This usually never happens if you have a large break. This usually happens when you have a small break close to the aura.
All right. I think we want to stay in time. I'm encouraged about the questions. We are here to answer your question. So now the next.
Yes. Ingrid, thank you very much. Just keep in mind, those percentages work the other way around as well. If you don't find a break up there and treat any other break, your chance of being successful is only 2%, 5%, 15%. Keep that in mind. So, Daniele Togneto, professor from the University Eye Clinic in Trieste, again, a very experienced non-drainage surgeon, will tell us what you can do in preparation of surgery.
Thank you. Good morning, good afternoon. But Ingrid, thank you for involving me in this beautiful course again. This is a picture from Trieste in 2023. Before starting, let me say some few words. This is, for those of you who don't know, this is a 140 edition of this course. So imagine how many young surgeons Ingrid has trained during these years all over the world. So we are very grateful for this. And believe me that if you listen very carefully to what Ingrid says to you, you will change your approach in retinal surgery. And so, believe me. My topic is ambulatory double patching. What does it mean? So this is a simple maneuver, actually simple maneuver. And you see from the picture, both eyes of the patient have to be covered with a gauze patch held in place with a single strip of paper tape placed diagonally across them. So the patient should be supine in the bed or by 30 degrees. It depends on the condition required, the double patching. This maneuver has been proposed by Stellwag, an Austrian ophthalmology. Maybe you remember from the sign in thyroid eye disease. And his proposal was that both eyes was bandaged and the patient lay supine with the head blocked by sandbags for many days, so very challenging for patients. They stuck on the bed in the dark for many days, and so it was a strong maneuver. And after that, in 1976, Auer even proposed to immobilize the eye with suture on the recti muscles and noting partial retinal flattening in half of case about. So eye blocked. And how does ambulatory double patching work? So you all know that, and you have already heard from Thorsten, that the main cause of retinal detachment is the traction and the retinal break, and the fluid comes through the break in the subretinal space. And the ocular movement, which are among the most rapid movement of the human body, promote the progression of the retinal detachment. And how do they do it? First of all, in presence of traction, the retinal brake, they cause a strong traction of the brake that creates a negative pressure in the subretinal space and the transit of fluid from the vitreous cavity in the subretinal space. And this has been demonstrated by this experimental study based on a mathematical model simulating the traction applied to edges of a retinal hole. And they demonstrated that this creates a vacuum drawing fluid flow into the subretinal space. And second, the eye movement increased the speed of intraocular fluids, and so they penetrate more easily through the brake under traction. So the eye movement is the matter. And conversely, if you stop the ocular movement, you reduce the vitreous traction on the raptor, the speed of ocular fluid and the transit of the fluid through the brake in the subretinal space. So the purpose of double patching is to reduce the eye movement. And we have to explain to patients this because we should have the best compliance for our patients to stay in the bed supine or for maybe 2 or 3 days. So we can use this technique in 2 main circumstances. One, bullous retinal detachment. You have already heard from Ingrid the causes of bullous retinal detachment, and the other is the vitreous hemorrhage. Let's start with the bullous retinal detachment. It originates from a superior brake. And many times in bullous retinal detachment, it's difficult to localize the brake because of the parallax. So this should not be the reason for moving to a larger operation, to a vitrectomy or what, but we have to wait. Double patching for a day or more will cause many times flattening of a bullous detachment, making it easy to localize the brake, making it easy to treat the brake without doing a vitrectomy. And let's move to the other cause is vitreous hemorrhage. You will know that the causes of vitreous hemorrhage are different: retinal vascular disorder, retinal vascular abnormalities, microaneurysms, etc. Breakthrough bleeding coming from a new vascularization, colloid and new vascularization. But as far as we are interested today is rupture of a normal retinal vessel happening during a retinal break. So during a posterior vitreous detachment, if a large retinal vessel becomes torn, we have a vitreous hemorrhage. And many times, rupture of the vessel corresponds also a retinal break. And the incidence of a retinal break during a PVD ranges from, you see, from 6 to 18% of cases. But if you have a vitreous hemorrhage, when you have a PVD, this incidence rises to 30 to 90% of cases. So if you have, after a posterior vitreous detachment, a vitreous hemorrhage, 90% of cases we have a break. Of course, if you can't see the fundus, we have to perform an echography. And we have to suspect the break if the other eye is perfect. It's not diabetic, it's not neovascularization, for instance. So the diagnostic routine with repeated echographies lead to an excessive delay in the diagnosis of the tear. So we should use the binocular patching. So we should know the kinetics of vitreous hemorrhage, because when the detachment of posterior haloids causes a retinal hemorrhage, the retrohaloidal space fills with blood. And the vitreous gel in front of that remain clear because the posterior haloids is impermeable to blood. And in the day after, there is a dispersion of the blood inside the retrohaloidal space, and this is due to the separation between these two spaces by the posterior haloid. of course, if we stop the eye movement, the blood gravitates to the bottom of the space, making possible to see the fundus, to find the break, and to treat the break. These are the pictures coming from the crisis book, and you can see the vitreous hemorrhage clears, and you can recognize the break. You treat the break with laser or cryo. If holes from the posterior haloidal, the membrane, the blood will enter the vitreous gel, and so the view is not good. Even you binocular patch the eye, so you can move, in this case, through a vitrectomy. To conclude, this is a series published by Harvey Link of Ingrid Kress in 2004, where 9 patients with vitreous hemorrhage, retinal detachment, or both were treated initially with binocular occlusion. And after this treatment, they treat only 3 out of 9 patients with vitreous hemorrhage or retinal break. This is patient 2, that very briefly, examination show a vitreous hemorrhage, outlines of an inferior detachment were visible, and horseshoe tear was discovered at 8:30 position, both eyes were patched, and that the vitreous clear sufficiently overnight to show that detachment had regressed, and they can treat the break at 8:30 without any surgery. So they have retinal detachment, the retina flattened, they recognize the break, they treat the break without any operation. The patient 4 is quite similar. Again, the retinal detachment without retinal breaks was decided to buckle the line of traction, you see, the day after the binocular patching with a sponge. And last case, we have a bolus retinal detachment. The break appeared to be posterior to the equator because of the parallax, but both eyes were occluded the day after. It became apparent that the tear was located anterior to the equator, and they can treat this detachment with a sponge. So the take-home message from this talk is use the ambulatory double patching as an alternative to urgent surgery in patients with a vitreous hemorrhage, because double patching allows the blood to gravitate in the bottom of the retrohaloidal space, and in patients with a bolus detachment, because double patching causes flattening of a bolus detachment, making it easy to localize the break, to treat the break. So use binocular double patching. And remember, the less is more. Thank you, Ingrid, and thank you all.
Any questions?
So it's okay. So Dr. Daniel, why is it important to eliminate the parallax, and what is the significance of the break being either anterior or posterior to the equator?
You know what is parallax? You mean you believe that the break is in one place and the break actually is in another place because of the parallax of your view, because there is a lot of fluids under the retina. So we have to wait for the retina flattening, and then you localize better the break, and you can treat the break in the right manner, because you risk to fail the surgery because of your sponge is not the correct place. So you put a sponge more posteriorly than the right place. This is the effect of parallax. Questions? There is a question for there.
We're mentioning the double patching in vitreous hemorrhage, because otherwise then there is a certain period of time, because otherwise the blood enters the vitreous gel. So which is your window of time? Which is the period of time you give before asking the patient to do the maneuver?
Well, we usually wait for 1 or 2 days, both in retinal detachment, bolus retinal detachment, or in vitreous hemorrhage. So we wait for 48 hours.
Yeah, but I mean the patient who comes with a vitreous hemorrhage, a recent vitreous hemorrhage, how recent has to be to ask him to make the double patching? 2 days, 3 days, 5 days, more than 5 days, or you?
You mean is the viscous hemorrhage lasts for 10 days?
Yeah. Would you apply the double patching?
No.
Not
in viscous
anymore. Yeah,
hemorrhage
this is
no.
crucial, I think,
Yeah.
just to decide that something can
Fresh
be done
hemorrhage, yes.
in the first 3-4 days, no more, because then the vitreous enters, the blood enters the vitreous gel, and so you won't have the clearance anymore.
Maybe Ingrid would like to.
May I just add something? Something I would like you to take home after this lecture, double patching. It can be ambulatory, as he said. When your patient is in Australia and he wants to come home to have surgery with you, if the patient does double patching, even in the plane, walking to the plane, a detachment never progresses. It gets flatter. And what's important, it never will detach a macula which was not detached. So double patching prevents progression even to detach a macula. And that's important to give your patients who travel far away to know where they go, where they want to be treated by you in Europe or in Asia or in America. Okay?
One more question.
Last question.
Yes, my question is if I asked the patient that she should lie down, and I put double patches on both eyes, and I tell her that she should be immobile, then eventually she will go to sleep, right? And there will be a REM phase with rapid eye movements. Doesn't that pose a problem or defies the purpose?
To understand perfectly your question. You mean if I put the patient in the bed?
If the patient goes to sleep, in her sleep there will be
I see.
a REM phase with rapid eye movements.
Well,
And
we can block
that's
that.
against the purpose, right?
Well, it does, we can't block the eye movement during the sleep, of course.
No, but again, the RAM times are a few minutes, a couple of times during sleep. That is too little to endanger the effect of the double patching. So the REM movement does not cause any harm. So you don't have to worry about it. It still works. Otherwise, it wouldn't work at all.
Yeah. I should add that the main cause of failure of double patching, we are finished. The main cause of failure of double patching is that the patient is not complaining. That's right.
Okay. Thank you very much. So something that works should not be avoided, even though it's unpopular. So double patching really works. Next is Professor Abhishek Kothari from India, a very experienced vitreoretinal surgeon and non-drainage buckler. And he will tell us why drainage is not necessary.
Thank you so much, Dr. Thorsten and Dr. Kreisig for this opportunity. Now, when we talk about buckling, the usual sequence of steps that comes into people's mind is that you localize the break, you treat the break, you do a buckle, and then you drain the fluid to bring the retina right next to the buckle. But I'm going to tell you why that is really unnecessary and why you can keep scleral buckling or the treatment of most of your retinal detachments a completely extraocular procedure. You don't have to enter the eye at all. So why is drainage? What is needed to reattach a detached retina? We all heard that you have to find, and of course you have to close the break. So closure of the break does two things. It stops the flow of fluid from the vitreous into the subretinal space. And by doing this, it allows the RP pump and the osmotic forces to empty the subretinal space and allow the retina to reattach. So this is the aim of your retinal detachment surgery. Drainage does not come into the picture. So this is what happens when there is a detachment. So you can see the layered structure of the retina, a break, and this is lifted off from the RPE. The fluid from the vitreous enters through the break, goes into the subretinal space. The RP pump is actively working to drain this fluid out of the subretinal space, but sometimes it is overwhelmed by the flow into the space. And that leads to an increasing retinal detachment. Now, what happens if you're a perfect buckler? You've done a perfect buckle. This is your buckle there, and the break rise flat. The retina is opposed at the apex of your scleral buckle, at the mound produced by the scleral buckle. Now, this is going to completely stop the fluid from going into the subretinal space, and the RP pump is going to empty the subretinal space of all the existing subretinal fluid. Now, this does not require any drainage. If you've done this, you can go home, sleep well, and the retina, even if you've left a lot of fluid, the next day will be completely flat. But there are some other situations. What if your buccal is here and only one part of your break is on the buccal and the rest is not? In this case, fluid will leak from the vitreous into the subretinal space, and the solution here is not to drain. The solution here is to revise your buccal. You have to change the position of your buccal to get it into position. A more common thing which sometimes happens is that you have done a buckling, your buccal is perfectly below the break, but because the fluid is quite a bit, your retina is not in apposition with the mound or with the RP at the top of the buccal. Now you may think that this probably represents a perfect situation where we need to drain. So do you need to drain now? In every language possible, I refute this. Do you want to know why? So we'll look at the altered fluid dynamics when this kind of things happens. So this is the buccal. What happens when you've put this buccal here? The fluid from the vitreous is going to try to enter the subretinal space. However, the space is less now. The RP is pumping away the fluid from the subretinal space. There is a study creating a model of a retinal detachment with a buccal in place where they found that once this contour of the RP is altered and the retina is brought slightly closer in the range of approximately 3 mm away from the apex of the buccal, this is what happens. Fluid egresses from the break with every saccade. With every saccade, the fluid in this area gets pushed out slowly out of this break. And this is most with the saccadic movement and least with steady movements of the eye. So the fluid tends to start going out. What does this do? This basically creates a negative pressure in this area and in the area that is further peripheral. They've done the same finite level modeling, finite mathematical modeling, which Dr. Daniele just demonstrated to you. And they've found that the pressure in this particular area is higher in the region of the break and the peripheral leaflet. The pressure in the subretinal space goes less than the vitreous. Why does this happen? You must have all heard about the Venturi effect. We all use it in the Venturi system vitrectomy machines, that when you create a constriction, the velocity of the fluid increases and the pressure decreases. So this does what? It helps us. How does it help us? Just look at this. If you blow between two balloons, they don't go away. They come towards each other. So this is what happens to your retinal leaflets too. The retinal leaflets get pulled towards the buccal with the saccadic eye movements, resulting in a closer and closer and closer approximation to the buccal. And when this happens, the saccadic outpour of the fluid also increases, thereby leading to a final retinal reattachment. Is there any evidence for what I'm saying? Of course, this is from published literature, but is there any clinical evidence of what I'm saying? Dr. Kreisig and Dr. Linkoff published this more than 50 years ago. And one of the people who was key to spreading pneumatic retinopexy, not buccal, he also did a study where he compared about 50 cases of non-drainage surgery to 50 cases of drainage surgery. Way back in '81, Dr. Hilton, and he published data showing that non-drainage surgery was safer, had less number of complications, and was equally effective to drainage surgery. Is this a thing of the past? We are talking about studies that were done almost 50 years ago. Is this a thing of the past? No. Till very recently, we have follow-up of over 15 years from Dr. Kreisig's studies. And recently, just this year in Retina, they have published a non-drainage scleral buckling series where they have found excellent results and increased safety over drainage surgery. This is hot off the press. So non-drainage is quite relevant. Does it work? Absolutely. Otherwise, we would have given it up a long time back. However, there may be some who have an urge to drain. You cannot stop yourself because you think there is too much fluid. I can't leave the operating table like this with the retina dancing about, and then they go ahead and drain. So what happens? What should you be aware of? Be prepared for a dry tap sometimes, a hemorrhage when you're draining, and when this happens, then you're in real trouble because this is what it looks like later. That blood will track there may be a choroidal hemorrhage, the subretinal hemorrhage, it may track if it's a macula off detachment under the macula. And then you end up converting this surgery into a much bigger, much more morbid procedure. You can sometimes, if you're not careful, create an iatrogenic retinal tear, a retinal incarceration, and all the problems associated with it. So I'd conclude my talk by saying, best avoid what can be avoided. Keep an extraocular surgery, do not convert it into an intraocular procedure. Thank you.
Thank you for this good explanation that comes from India, where between the continents. He tells you what not to do. Are there questions?
Yeah, hi. Nice talk, Dr. Abhishek.
Please, your name and your country.
I am Dr. Gagan Bhatia from India.
Oh, also from India.
Yeah, so we have, so sometimes there are situations which very nicely described about this, but sometimes you have situations where when you don't drain and you have a perfectly placed buccal and you have no missed break. So very specific question, right? But if you have a detachment which is not so fresh, and as you say that it's the RP pump which is pulling, so how long would you wait to not do an adjuvant gas injection or something in which there's a macula off, there's a sliver of fluid over there still left? So how long would you wait?
So in most cases, you don't have to wait for more than a couple of days. The break usually comes in approximation to the buccal. And then slowly the RP will pump out all the fluid from the subretinal space. If it's a chronic retinal detachment, it may take sometimes a couple of weeks or even a month. But if it is a fresh detachment, you'll be surprised that in 1 or 2 days, the whole retina becomes completely dry.
So still no drainage and still no gas tamponade?
Yeah, absolutely unnecessary.
You see, it has infiltrated already India. Another question for Dr. Kothari? There's a lady. No. Please use a microphone when you talk, that we know from where you are coming. All right. Let's continue. Thank you again for your excellent talk. Now, the next, Professor Mennel, chairman in Austria. He is a kind of a pillar of our teaching course. We have now teaching course 140, and he was most of the time with us. So expect the expert in teaching.
Dear colleagues, now you've heard about finding the break. Now the question is how to perform minimal buckling treatment. We want to discuss it with the following topic. And it sounds something mystic to reattach a retina without going inside to the eye. What is sufficient? We have heard preoperative examination. All breaks have to be found. And now the topic is how to make a tamponade on all these breaks. A very important question to this is which buccal should be used. And if you look, and you have heard from Professor Kreisig, almost about 90% the retinal break is about the disc diameter, or a little bit less, it's about 1 millimeter. And if you look, if the retinal break is 1 millimeter, we should take 1 millimeter to either side. Therefore, if we have a 1 millimeter break, go for a radial buccal to be sufficient with 3 millimeters. And if the break is 2 millimeters, 1 millimeter to either side, then you have a buccal or a sponge of 4 millimeters. And to the mattress suture, because you should suture with tension the sponge to the sclera, the measurement and the width can be calculated as half of the circumference of the sponge. Therefore, at a 3 millimeter sponge, go for a 5 millimeter width of the suture you use. And in a 4 millimeter, go for 6 millimeters. And if I look to my own, all the cases we prepare, the 4 millimeter sponge is the sponge we use in most cases. And only in rare cases we go for a 5 millimeter or in an oval one of 7.5 millimeters. These are cases we will rarely use is the 5 millimeter, and because the break is 3 millimeter, and then you use the mattress sutures, half of the circumference, it's 8 millimeters. And on this drawing, I point out how to find out how large the retinal break is, because we can assume, yes, it's about 1 or 2 millimeters, although when you are experienced, it's helpful to mark the retinal break. You need the binocular indirect ophthalmoscope, using during surgery, go and do the indentation and mark the borders. And then you can see in the horseshoe tear, at the base of the horseshoe tears and the apex. And if you have marked it, you can measure it. And if you have a measurement of 3 millimeters, yes, you need, the sponge should, 1 millimeter to either side, it should be 5 millimeters. The possibility of a video we will show afterwards. We have an own session with all the presenters have their own video to present. Therefore, I will present it afterwards in the video session. And what is important, if we press the suture there and compress the sponge, afterwards we look into the eye. We look to first to the eye pressure. We look to the central artery, and then we look to the buccal if the buccal is placed on the right position. If not, I remove it and put it on a better position. And as we heard already, the buccal does not have automatically to touch and the retinal break. It could be a little space in between. It's important that the place is correct. And the intraoperative localization and the indentation in the marking is important, and to avoid parallaxis. In a discussion later on, we will also go on the topic to prevent parallaxis. Because it's very important, if the retinal break is in the periphery and the retina is only detached very shallow, it's easy to mark the retinal break. But if the retinal break is in the very center and you have a high bullous detachment, the risk is that the indentation and the marking is not on the right position due to parallaxis. And for these cases, go and start with the indentation once more from the very periphery. We also heard double patching is helpful to reduce the height of the retinal detachment. It's much more easier to find and to mark the exact place of the retinal break at the sclera. And the question is, if I have a retinal break or more retinal breaks, which situation, which should it be performed as a radial or circumferential one? And as you see on the left, and on the right side, it's much more easier, whenever possible, I go for a radial one, because it's much more easier to support the central and also the peripheral part of the horseshoe tear where the traction is most. It's much more easier than using a circumferential. A circumferential is necessary, yes, if there are many retinal breaks in 1 or 2 clock hours beneath. But in other cases, to counteract fish mouthing, it's easier to take the radial sponge. Now the question is, for which cases can only extraocular procedure, a minimal procedure, be successful? And as we know, and as we can see here, yes, small retinal detachments, because we have a retinal break, we treat the break, we perform a buccal at the retinal break to be successful and reattach the retina. But the question is, what to do in a total detachment, 360-degree detachment? Is a minimal buckling treatment possible for these cases? Yes, we do not treat 360 degrees detachment. We only treat the retinal break at 11 o'clock. The treatment is the same. It's a small sponge placed at 11 o'clock. It needs time for the subretinal fluid to resorb, and then the retina is attached. The next question, an inferior detachment. Is it successful in these cases? Yes, because we perform a buccal exactly at the retinal break, and even more, compare it and discuss it with vitrectomy. Inferior breaks, they are difficult because of the tamponade of gas, of oil, and all these cases of the inferior part in PVR progression. For these cases, also minimal surgery is possible and effective. So to sum up how the technique should be performed, the marking at the sclera is important. Measuring if it is a greater retinal break, mark the borders and calculate the size of the break and calculate the sponge used. Then non-drainage and the size and orientation, if possible radial one. And the fundus examination afterwards is necessary for the central artery and also looking if the buccal is on the right place with the necessary height of the buccal. Also, after success, we have also to discuss risks from the procedure. It goes about suture placement, cryo, and the sponge size. If we go for the suture, it's very important the tip of the needle should be within the sclera. It's 1 or less than 1 millimeter thick, the sclera. And when going through the sclera, be aware, don't rotate the needle, because otherwise there's the risk of perforation. Cryocoagulation, important, don't over-freeze and look that the tip of the cryoprobe is on the area of the retinal break and not the shaft. If in doubt, go out and go in once more and start with the indentation from the very periphery. Here one case, you see on the left side, over cryo, it's 2 days after surgery, still it's white, and the buccal was placed here in the periphery, not exactly at the area of the break. What we did, we removed the buccal, put it beneath the retinal break, and then the retina attached afterwards. And concerning the complications, perforation by suturing is less than 2%, which may cause vitreous hemorrhage, subretinal hemorrhage. Infections of the sponge, rare cases of less than 1%. Buccal extrusion, if you remove the conjunctiva and the tenon, very exactly, it's rare, but it's also less than 1%. And also the discussion of diplopia when the buccal is very near to the muscles. For these cases, it's also less than 1%. And what to do in these cases? Because the buccal is only needed at the time to reattach the retina. When weeks later the retina is attached, do we need the buccal anymore? No, we don't need it. But if we have problems with the buccal, we can remove the buccal afterwards when the retina is attached. So what about the functional results? It's important to know what are the results. And here there is a study from Professor Kreisig. She looked for patients, 107 cases, not for 1 year and not for 2 years, and also not for 5 years. She had a full follow-up for 15 years of all these patients where she has performed minimal treatment surgery only outside from eye without drainage. 61 patients had a 1 to 2 quadrant detachment, and in 46 cases it was a 3 to 4 quadrant detachment. And a radial buccal has been performed by Ingrid Kreisig in 71%, a circumferential in 19%, and a combination of a radial and circumferential buccal in 10%. And she had a single success operation of 92.5%. And she looked very exactly to those patients with failure. And it was another break in 2 cases, an inadequate buccal in 4 cases, and no hole that could be found in 2 cases. And looking to the number of reattachments or redetachments in the follow-up of 15 years, it was 1% for each month in the first 6 months. And in all the other follow time of the 15 years, it was less than 0.5% for each year up to the 15 years. And if we ask the patient what's about the results, the patient is not interested if the retina is attached or not attached in the first time. He is interested to have a good visual acuity. And Professor Kreisig had summed up visual acuity over the 15 years and could see that there's an increase of visual acuity within the first year and a minimal decrease over the 15 years. And then they subdivided the macular involvement in 3 groups of non-partial or total macular detachment and could see the same follow-up time. The visual acuity was best, of course, in the macular on group, less in the macular off group, but in all groups, visual acuity decreased in the first year and a slow decrease over 15 years. Does this respond on the minimal surgery or not? How to find out? Ingrid said, yes, we have to need a control group. And which is the control group? It was the fellow eye. And looking to the fellow eye, she could see the same. In the follow-up for 15 years, it was a very small decrease of visual acuity in the fellow as well as in the treated eye, which can be concluded that minimal extraocular surgery does not have a negative effect on postoperative vision in comparison to the untreated fellow eye during a 15-year follow-up. Thank you very much.
Excellent talk. Thank you very much, Stefan. Any questions?
Rajesh Shroff from India. I had a question. It's a beautiful presentation, but a certain specific situation, like I have a retinal detachment with a large retinal cyst, and it's draining superior from a dialysis. So how would you use your segmental buckle in such a case? And would you like to do something special for the cyst?
For dialysis, yes, after traumatic cases, it's very typical, and you have a 100% successful treatment if you have oral dialysis, that we know as the vitreous is attached in these cases.
And what manner would you like to place, for the sake of the audience, the buckle in those cases, in the dialysis cases?
Pardon?
Would you like to put it circumferential or radial?
Circumferential,
Yeah,
all over the area where the dialysis is.
And if you have a retinal cyst, a large cyst in the retina, chronic cyst, so for the young retina specialists, anything you would recommend in those cases?
A retinal cyst,
Chronic cyst.
It's no difference.
Yes. If a
You close the
detachment,
break.
no, if a detachment is very old, you are a very good observer, there might develop cysts
Yes.
and a pigment demarcation line. Pigment demarcation line after reattachment persists, the cyst in long term might collapse.
Okay.
But don't treat it, don't do unnecessary surgery.
Thank you.
Think.
Thank you.
It was an excellent presentation, as I said it would be. Now let's continue.
There's one question.
What? Yes, country and name, please.
Dr. Ankita from India. So just wanted to
country?
India.
India.
Just wanted to understand clearly. You said that there is a large tear at 11 o'clock, and there are multiple small breaks inferiorly. We would only treat the superior 11 o'clock, and is that what you said? I just want to understand that.
No. I didn't say that there is a break in the superior part and there are breaks in the inferior part. I said there is only one break. The case I presented was a total detachment with only a retinal break in the 11 o'clock position. There are on the incarceration and on the area of the detached vitreous, there are small hemorrhages. You don't have to treat small hemorrhages. You have to treat all the retinal breaks.
I was wondering if
this would be a mistake.
That clarifies.
There are small hemorrhages you don't treat, only treating the originating. There was only one retinal break that was at 11 o'clock. Only the sponge at this area.
Thank you.
I think it is marvelous. We heard Dr. Kotari, his excellent lecture, and he has really stimulated many young people in India to be critical, remain critical. That the success of you feeling good, you become an excellent surgeon. I think we have to continue to stay in the time, not to be thrown out. Please announce the next speaker.
So I want to call Vincenzo Ferrara from Italy. Vincenzo is another pillar of our cause who has been around for at least 30, well, no, he looks much younger, for 30 years. No, but what do we do when we see after our surgery fluid under the retina? So Vincenzo will start with the topic. Vincenzo.
Yeah, thank you very much. You know, I joined this family in '91, just at the first. Yeah, I was in Tübingen. I was working there, and I tell you, the Ingrid Kreisig and Harvey Linkov, they were really my most important mentors in my activity. And for the simple reason, what they said at me at the first day, and you were repeating this today again: be logical, because the retina is logical. So be logical, be critical. So, of course, this is whenever you don't drain, the day after, it may happen to have still some liquid, some subretinal fluid. But because you remember, because you remember, comparing to the inversely to the vitreous surgery, where the retina is flattened intraoperatively, in episcleral surgery, moreover, if you do the true one, so without drainage, the retina flattens if everything is well correctly managed and correctly judged. No? And so given a retinal detachment like this with a single break or 2 breaks in 1 clock hour, and treated with a non-drainage procedure with a simple buckle, there are at least 3 reasons for a persistence of fluid, which is the first, the delayed absorption, or a persistent leakage, which means finally a rhegmatogenous detachment still persistent there, or tractions, which can be under the retina or over the retina. But basically, you can distinguish these types by 2 main configurations, which are convex borders, convex surface, or concave borders, concave surface. And then other features that we're gonna see. Shape and contours, again, they are basic to understand which is the reason for. So let's start, for example. This is a case, very simple one, preoperatively. This is the first day after the surgery, no drainage. So what is this? What is subretinal fluid remaining there? Look at the borders. Look how, at first point, the borders, they dropped inferiorly, and they are, all the subretinal fluid shifted far away from the buccal. So this area of retina is dry. This is very important. And again, look at the borders. The borders, they are concave, convex to the ora serrata. And this is crucial. They are not anymore perpendicular to the ora serrata. Of course, this is a drawing. This is very simple. In reality, it's not as strict like here, but we have to be clear. You have to understand in 3 minutes what I mean. So I show you a very detailed. And so this is a delayed absorption. This is not a rhegmatogenous detachment. This is subretinal remaining fluid. What are the reasons for? There may be an insufficiency of the retinal pigment epithelium because they happen in highly myopic eyes, or elderly patients, they can have incompetent and not completely competent retinal pigment epithelium, or you may have concomitant choroidal detachment, which lowers a little bit the reattachment, the effect of the pump. But in any event, the macula is attached. You know that you did the you have the, this is true because you didn't remove any leakage. So what is missing is because you did the right things. No, it's so send the patients home. This is another situation. You may have this pattern, which is more or less the same of yesterday, of the day before. So what does it mean? But for sure, this is another brick, because if you look again at the shape, this is the same appearance of the day before, of preoperatively. So this is an overlooked break superiorly, and that cannot be inferior, because otherwise you would have changed it. So this is something which has to be, which has to go to the surgery, as well as this one, where you see here the borders. Here, this subretinal fluid has borders which are vertical to the ora serrata, and somehow this is a fluid which moves more than the other we have seen before, which is a little bit more shifting with the movements. And this is a break missed. So this is again another detachment which has been treated. But the other appearance is that one. The first day, if you look at the image, this pattern has a concave configuration. So the retina, the borders are concave to the aura, and they are concave to the part of the retina, the central retina, and the borders dropped inferiorly. So the macula is dry now, and the fluid shifted away, and the fluid, and you can see the appearance of subretinal strands which were not visible before, or even subepiretinal strands which were not visible again because it was bullous, so it was masked somehow by the retina folds. But again, In addition, look how the retina on the buccal is dry, and how the detached retina is very less mobile. It's not mobile, and the fluid in this case is immune the patient the day after. You can't tilt the patient on one side or the other. The fluid doesn't shift, and this is probably one of the most important signs, together with a concave XP. So this is a PVR finally. And in this case, it's not a matter of redoing. In this case, just wait because the macula is safe, and this fluid will be reabsorbed within weeks or months. But in any event, the macula is safe, so the patient can regain the visual acuity. And even if it persists in 6 months, wait again, because even the patient cannot appreciate this. And this is the final message. If you see the retina still attached today, this is not necessarily a failure. Be always. And I will add at the end, it was already mentioned even by Dr. Kotari, and so this persistency of submacular fluid is becoming of interest even for vitrectomists, because the way the retina reattaches by itself, so the macula fled down slowly, right? So is much safer than when we do it in a very fast way using the perfluorocarbon or during vitrectomy. That goes against the retinal displacement, and these are the proofs, clinical proofs in favor of it. Thank you.
Thank you for this clear-cut description for what you have to look. And I just would like to ask you whether you agree, Vincenzo, when you have this delayed absorption, curving back fluid at the bottom, would you not like to ask the patient to sleep elevated overnight? What would you say?
Yeah, I forgot it. This is the only thing to suggest to the patient. Yeah? The sleep with some pillow, not to stay just lying down supine, strictly supine position, but do your activity. Go home and make your activity, which is one of the advantages, even again, comparing to vitrectomy. I'm a vitrectomist. I do mainly vitrectomies, and I don't do only buccals. But I say, in some cases, if you have needs for any activity the day after, because it has to fly back, the only way of doing something which works, it's to do a buccal, because with the buccal you don't need positioning, and you don't need. Thank you.
Vincenzo, thank you very much. You covered both the delayed absorption and the subretinal and the failure, so we can step right away to the next question, and that is the historical look to encircling bands after 50 years, because encircling bands throughout the world are still quite popular. And Stefan, again, in his meta will show us what you have to think about encircling bands after 50 years.
Dear colleagues, this presentation should be given by Professor Kreisig, because she is the one, she has the experience, and we now have to looking back 1960, 1970, to this time when many things in retinal detachment has been found out, changed, and treatment strategies had been changed. And looking back is very important, because in 1929 it was Gonner who was the first to find out that we do not have to treat the amount and size of the detachment. The originating retinal break has to be closed. And it was Scapens in 1954 who treated the detachment and the retinal break, and he was the one who introduced the cerclage on the basic work of Aruga, the historic Aruga suture that was being performed surrounding the entire 360-degree, and with this to secure the posterior retina. And how it came about. If we look all back to the historic time in 1950, 1960, we have to think at a time when we were not able to see the peripheral retina as we see today. They hadn't had the binocular indirect ophthalmoscope with the quality we have today. They hadn't had the contact lenses, 3-mirror or panfundoscopic contact lenses, and they did not do intendation as we do it today to precise find all findings in the very periphery where the originating breaks are. At this time, there was a suspicious area in the very periphery, and it was the time when they performed a buckling treatment, and still there was retinal detachment, subretinal fluid moved on. It was the time when it was thought making a barrier is much more easier to wall away this periphery. We do not know what is coming next. If there is an additional break, we do not know, we do not see. And then they increased the size of the circumferential buckling, and they performed retinopaxy. But nevertheless, they had cases where the fluid accumulates more and more, come again, and redetachment occurred. And more the circumferential became 360 degrees, following and called the cerclage. And it was the time of maximum treatment. It was performed subretinal drainage, as we have saw the video before, subretinal drainage to remove subretinal fluid at this time. The ocular pressure decreased to compensate the cerclage was ideal because we had the function of the cerclage to increase the eye pressure. And it was the time of wall away all uncertainties of the very periphery. It was also a little bit prophylactic because it was thought, what is in 2, what is in 3 years? It was the time of prophylactic treatment when laser and cryo came available, and we did a lot of prophylactic treatment we do not do today anymore. And the cerclage had the possibilities of compensating the hypotony and drainage, and it was a new barrier. It was called a new ora serrata, but this was not true as redetachment could show afterwards. And the third point was, it was because of vitreous traction in the periphery to compensate this, the cerclage. For this time, it was a successful treatment. And if you look to this case with 3 retinal breaks, of course, years ago it was very good to perform a cerclage. Today we know a cerclage is not needed. 3 radial buckle will be successful to only treat 3 retinal breaks. The cerclage and the surgery implies drainage, which had complications of less than 40% with intraocular hemorrhage, choroidal detachments, and also vitreous or retinal incarcerations, and as well anterior and posterior ischemia. And here you see the arruga suture going through the sclera, through the choroid into the eye. And it was shown in several studies that the constriction by a cerclage causes ocular pulse was reduced, the retinal and choroidal perfusion was reduced, as well as decreases in visual field. And it was Ingrid Kreisig and Harvey Linkoff. They could show presented the pulsatile ocular blood flow in the fellow eye compared to the eye of cerclage that was significantly reduced. And they can show in another study that the patient with the cerclage, and the cerclage was cutted, and due to cutting the cerclage, there was an increase, significant increase of the pulsatile ocular blood flow. And normal compliance is not encircled eye to systolic pulse versus limited compliance in encircled eye, as you can see here on the right side. About the anatomical results, we know reattachment, primary attachment was in 85% at this time, and with multiple reoperations, it was 97%. So today, we know more. We have the experience of the minimal buckling treatment, and it's not needed as a barrier against the undetected breaks and the periphery. We can today search for the breaks. And to support presumed anterior vitreous traction, it's not needed today. In these cases, we go for primary vitrectomy. And for multiple breaks, it's not needed. We only perform the buckle where the retinal break is. So, as an option to sustain a buccal height if needed, yes, you also can change to a larger buccal. And redetachment due to a receded buccal, alternative, you can perform a larger buccal. So therefore, no cerclage if one break, go for a local buccal. In several break, go for segmental buccals, and in vitreostraction in the periphery, go for primary vitrectomy. And almost non-indications. But if it's done, think about the results of the study presented before. To avoid long-term visual loss, cerclage should be cut when the retina is stable, the latest after half year. Thank you very much.
Questions?
Are there any questions?
No questions. So, Stefan, thank you very much. My next talk now is why is a minimal buccal without drainage sufficient? And this is no talk with pictures, it's a talk, a dialogue with you. Who of you is doing retinal detachment surgery? Please show of hands. Very good. Who of you is doing buccal procedures or encircling buccal procedure, whatever? Who is doing encircling bands? Who is doing primary vitrectomy? So, to all of you, who believes that you have to close all the breaks you find? Who in primary vitrectomy has found the breaks where the rules tell you they are? If you find during vitrectomy the breaks where they should be, is there an option to close them differently than with the primary vitrectomy? Yes, of course. So if there is evidence that the pneumatic retinopexy has better visual outcome, that sponges has better visual outcomes than vitrectomy, might that be a reason to change from primary vitrectomy? Yes. If pneumatic retinopexy has redetachment rates up to 15, 20, 25% and new breaks and up, is that a reason maybe to change the approach to primary vitrectomy? Yes. There were quite a show of hands with encircling bands. As I told you, when we were in Hyderabad, the clinic, they were Skepins trained. So there was bend and tire. So a bend around and the tire up to the aura. And it works, of course. But they were so keen on listening whether doing less would be as efficient. And I just can tell you from my personal experience, just based on standing on shoulders of giants, you know, what Ingrid and Harvey told me, I've done close to 4,000 non-drainage bucklings procedures. I'm not as good as Ingrid, and when I had failures, a part of that was due to my haste, not spending enough time to look, not placing the buccal correct, not double patching. So we teach things we sometimes don't do ourselves, but again, we should take the blame then. It's not the procedure. And in vitrectomy, the psychology is very nice. You leave the table with the retina attached. You press the retina, the macula on, and you laser, there's gas, and you are the hero. You sit there in the OR table, it's climatized, and you don't have problem. And you go to the patient, the retina's attached, we'll see how it works. But then when the retina redetaches, when the gas is absorbed, it's not your fault.
It's a difficult eye.
It's a difficult eye. It's PVR. It's not your fault. Other way around in sponge operation. You move around, it's uncomfortable, something is in the way, it's difficult to see, you place the buccal, it's a thin sclera, and the buccal doesn't reach the break. And you close the eye, the retina is as attached as in the beginning of surgery, right? So you have to take the blame because you go to the patient, you go to the wife and the son and the daughter. So, well, we'll see how it works. I did my very best. I placed the buckle, but the retina is still detached. We'll see tomorrow whether I was good or not. And if the retina does not attach, you have to take the blame. It's a totally different story than doing a vitrectomy. Are you strong enough to take the blame? If you're strong enough to take the blame, and if you do everything right, then a non-drainage buckle, of course, is more than sufficient to cure retinal detachment. And the main sentence Ingrid said is, the retina behaves logical. As long as you behave as logical as you treat the reason and not any pathophysiologic idea, then you will be sufficient. You will see in the video sessions that we have a lot of retinal detachments, and you may know that if you do encircling bands or buckles, where you have scleromalacia, where the sclera is very thin. Actually, the vitreous traction in this scleromalacia that is causing the break is not because the vitreous shrinks, but because the wall is wandering outwards. So the ideal treatment of a wall that's receding is pushing it back in. It's not cutting out the vitreous, right? So there's so many logical ideas if you try to think about it, and if you're willing to be not the hero sitting comfortable at the OR microscope, that speaks very much for just doing a non-drainage buckle, because you have a reward as well. If you place the buckle, if the buckle doesn't reach the retina at the end of the operation table, and in the next morning the retina is reattached, that is a proof of the quality of your surgery and your observation. Because then you know you have not misjudged the case, you have placed the buckle correctly, and that is your reward. You get a reward. And in vitrectomy, you should take the blame as well if it detaches after 2 weeks. So I hope that all the talks up to now could show you that with a logical approach, with a self-critical, with a humble approach to your possibilities, to your abilities, you will do a better service to the eye and to the patients than if you just follow schools of thought. There's nothing wrong with bent and tire. You saved a lot of eyes. There's nothing wrong with primary vitrectomy. But there's evidence that there are drawbacks of those techniques. And we just want to encourage you to be open-minded. Try to do something else. Start with an easy detachment, just a break, with a larger accompanying detachment, and then build up your self-esteem, your trust in the technique. And I can show you, I've done that now for more than 30 years, and let's say 4,000 cases of non-drainage buckles. If I would have a retinal detachment, I hope, first of all, I don't get anyone at any time, but if I had one, I would want to be the one that can be buckled, and then I hope I will find somebody of you who's experienced at that time in 10, 20 years that I can go to. So please, if at all, a buckle possible detachment. Thank you very much.
Thank you, Torsten. I mean, that's a confession after 30 years doing minimal segmental buckle. And, you know, we want to be treated by you with a minimal segmental buckle. Are there more questions? Then we can continue.
You stay here, please. Because
I do it.
Yes.
I follow, you know.
Because the smart ones of you will have seen in Vincenzo's talk about the failures, that there are different types of failures. And Ingrid will tell us now that, again, with her analytic brain, she could find rules for finding the break in reoperation.
Yes. Now you have a reoperation. My God, now I have to do more. Or is it still possible to do the surgery of the break? But how do you know whether there is a break? Remember the contour. The contour tells you what is the cause to be treated. Now let's see. We did 752 retinal detachments treated with minimal segmental buckling without drainage. And we had failures. 87. Who likes to analyze their own failures and to admit we are not perfect? So we analyzed. And what were the results? Which were very astonishing. We didn't expect it because we were very carefully, preoperatively looking for the break. There was another break, or being honest, a not detected break, in 39 of 87. That means 45%. With other words, every second failure was due to the fact that we had overlooked the break. And we were very careful looking, the senior, the chairman, and the people who came on a scholarship to us, so the patients were examined. Now let's look here. We have a detachment which went from 5/9 to 11 o'clock. There was a horseshoe tear, 1.5 clock hour beneath the superior border. We followed the rules of the retina. The detachment changed. Was this delayed absorption? No, no. You remember, it curves back slowly towards the ora serrata. And we had a new type of detachment from ora to disc. And now, look to the right. We can lose rule number 1. You see there. Where should be the break? 1.5 clock hour beneath. Yes, and there is the break. But it's tiny. Otherwise, we wouldn't have overlooked it. How to find it in a reoperation? And you know, an eye which is up for reoperation, it's prone to get PVR. How can you provoke PVR? To depress too much, to do unnecessary diagnostic cryo. So you have to find right away the break. How to do it? We make a map as we have it for Girl Scouts or Boy Scouts. We go with the vessel from the disc. At the first bifurcation, you see, we go to the left. At the next bifurcation, to the right. At the next, to the right. Aha! And there is the tear. Now it's a reoperation. Should we not better drain now? No. Why? There is no traction. The contour is convex. Convex means the break has to be closed. And that was done. Rule number 1 for reoperation. This paper got published by Dr. Linkoff and I think in 92. It says, when the superior border drops below the buccal of a temporal or nasal superior detachment, it implies an undetected break, again, according to the rule, number 1 of the Linkoff rules, within 1.5 clock hours below the new superior border. The retina has also logic in a reoperation. And what tells you how to find the break? The contour. How do you determine the correct contour? Lie the patient flat, turn the head to the right, turn the head to the left. Now let's continue. Here we have another superior detachment with a superior hole. It was very large in the little hole, and there's a rectus muscle. We didn't want to have diplopia, so the buccal was a little bit too small towards 11 o'clock. The next day, there was a change. The detachment got smaller. However, there was still detachment at the 11 border of the tear. Now we had big discussion in our department. Yeah, perhaps the buccal is not large enough, or perhaps, one smart resident said, yes, there is a traction line. We need a vitrectomy. No, why not? The retina tells you, convex borders, there is a break. We didn't know what to do, so we didn't do the surgery. We better thought, we think. The next morning, we looked at the patient. The detachment did not progress. However, it even got smaller. It's not in the picture, I hope you can imagine, that the extent of the detachment was now from 1/2 to 3 o'clock. So the so-called fold was not the cause for the delayed absorption. The detachment had a new contour, and now you see again a detachment from 1 to 3 o'clock. Which rule? rule number 1.5 clock hour beneath, there should be a break. Yeah, they are lattice. Very often you find a hole in lattice. They are laminar holes, they are pseudo holes. So there was nothing. We didn't find anything. And then suddenly, a resident from Saudi Arabia was very careful. He was working 5 years with us. And he said, I think, doctor, there is a tiny hole posterior to the lattice. I said, posterior? Okay, it can be a hole. How do we find it? Very posterior and very small. We made again a map, the drawings for the vessels. We went along the vessel to the right of the first vessel, and then we went to the left, in between the tiny hole. Now there was another problem. It is around 22 millimeters from the limbus. It was a myopic eye. My God, a radial buckle so posterior. It's so difficult. What should we do? We had the balloon operation. We talk about it later on, you see. So we inserted the balloon, and what do you think? The next day, the retina was attached. And now a smart young doctor, it could be among you, I'm certain, would say, doctor, why did you not treat, when you once did surgery, why did you not treat the lattice to do prophylactic surgery? I repeat, we only treat what is needed today. We don't do prophylaxis. And by the way, this patient was followed up 3 years and it remained attached. Now, what is the conclusion? The balloon was, of course, removed after a week. Then there had been just some laser coagulations. Rule number 2 for reoperation. When the pattern of a detachment converts from one pattern to another one, it indicates an undetected, overlooked break consistent with a new pattern. The new pattern, the new borders of the detachment tell you where to look for. Now, this is a detachment from 4/6 to 11 o'clock. Very proudly, we found a horseshoe tear at 9 o'clock. And we thought it was so great. However, we were not good. Why? What do you say? The horseshoe tear at 9 o'clock is 2.5 clock hours beneath the superior border. I told you, the retina reacts logical. It was too far away. But we treated it, and the buckle was positioned very well, and cryo was done very well. However, the next day, the detachment did not change. It was not delayed absorption. It did not change. Now, what should there be the case? 2.5 clock hours beneath. There should be a tiny hole above. Of course, we found it finally. We made again the drawing with the vessels to find quickly the break. You remember, reoperation eyes are very prone to develop PVR. You should not indent very much. You should not do diagnostic cryo. You should right away find the break. What is the conclusion? Rule number 3. When the borders of a detachment remain unchanged after buccal operation and the buccal is still and correctly in the correct position, this implies an overlooked, undetected break above the buccal. So if you are a buckler and you don't look very well and you overlook a break, the retina tells you the next day, doctor, you might be quite good, but you are not excellent, you overlooked the break. Now, it's hard to realize this, but that's reality. The retina is logic and honest. Now, we have another patient. He had 4 cerclages with drainage, and all the time the retina detached again. The patient came for operation 5. What is important if you have a cerclage and a detachment to find the break? Look anterior to the cerclage, then you know the correct borders of the detachment. We did? Yes. Anterior to the cerclage, there is a total detachment. Now, we have rule number 2. We have book number 2 here. We should have Yeah, the rule, we have it here, it's number 2 of the first book. So this tiny little break should be anterior to the cerclage. And it has to be very much towards 12 o'clock. Why? Because if there is a cerclage, it is very anterior. And there's as well a traction line there. It should be vitrectomy. No, the contours are convex, and it's even bullous. That speaks that the break is superiorly located. This, now it's operation number 5. It was strained 4 times already. Should we now, doing just minimal segmental buckling, should we now drain? It's a 5th operation. No, convex contours, a sponge without drainage, the traction line attaches, and the retina reattached. Now, a critical person of you, I hope you're all critical and question all the time. Doctor, it is not completely attached. There is a detachment. We have to do a vitrectomy. Look at the contour. The retina tells you it is concave. There is a little traction. You mean down there had been done very much diathermy. The patient was looked up after several weeks. That had disappeared. Now, let's think about rule number 4. When a total detachment remains unchanged after being encircled and drained already 4 times, it implies, listen, an undetected break anterior to the existing cerclage, very close to 12 o'clock. The retina's logic. Be logic, and you understand the retina and you treat it correctly. And this is the book number 2. There we see the slides we show you already, and there are the rules. And what is now the next to look for? We analyzed our failures. Who likes to analyze failures? But now we have to be complete to tell you the truth. 27 eyes were not attached. Why? To be honest, the buckle was not placed correctly. We did not drain. Then it's difficult to place a good buckle without drainage. Every 3rd failure, 31%, were due to the buckle not being correctly placed. And if you put both together, overlook the break and inadequate buckle, in 80%, the failure was due to the fact that the break either was not found or not buckled correctly. Here, this is a case. The buckle was inadequately positioned. Of course, the buckle was a little bit too small towards 11 o'clock. Why? Rectus superior, diplopia, unhappy patient, despite the fact the retina might be attached. Yeah, the retina tells you what to do. There is still detachment going on top of the buckle. That means part of the horseshoe tear is leaking. Now, what to do? A big operation? If you have a balloon, we had at that time, we placed a balloon on top of the existing buckle, just under conjunctiva, very easy. The buckle is elevated, it absorbs, and the rest of the operculum is getting lasered. But if you don't have a balloon, what can you do? You can use a catgut cerclage. I may say catgut, not cerclage, catgut cerclage, to elevate the buckle. And we made experiments with this. Catgut cerclage dissolves by itself without a reoperation, without removal, after 3 weeks. Good idea. Or inject gas. Remember the paper about the gases. It induces traction, it might induce PVR, it reattaches the detached vitreous because it presses the vitreous back towards the retina, and it induces cellular reaction, PVR, new breaks. If you use a gas which is in the eye only 8 to 10 hours, and that's enough. Use xenon, and you can use xenon, and the retina will reattach. And now there are around 20 eyes. To be honest, we did not know what was the cause. And then we said, all right, it must be traction. And if a retina is attached after your operation, after your primary operation and after a reoperation, it is very important to explain to the patient to be sure that the retina is still attached. Why? In a very small percentage, a redetachment could occur in long-term follow-up. It was 0.5%, almost not, within per year over 15 years. However, a patient should be reassured my retina is attached. How does it do it? You have to show it the patient, not to talk. Close. I drink, sip, forgive me. Close one eye, patient looks straight. I see the mirror, and still being fixating, he sees there is a ceiling, there is a floor, and there's a wall and a bookshelf. So he knows the retina is attached. And you start at first to do this with a good eye, and the patient knows the visual field has to be round. So he doesn't have to come daily to you. He can, if he's uncertain, every day, my retina is attached, my retina is attached. And this are called passive prophylaxis. That's a very good thing to explain to the patient. Here we had a patient who was disastrously difficult. Not the patient, the finding. It had a giant tear from 6/12 to 3 o'clock, and the posterior retina was flapped over. At that time, we didn't have vitrectomy. And Dr. Linkoff and I, we described the small bubble technique. We unfolded the posterior retina, and the gas expanded by the time the retina got completely attached, and the posterior edge of the giant tear was treated with cryopaxy, and I think it was a miracle. The giant tear was attached without vitrectomy. But we told the patient to check the visual field, because you never know when you have gas in the eye, there could come PVR or new breaks. One day, the patient came in the office and said, "Doctor, I think there's something wrong." I had a young doctor from Morocco who looked and said, "Dr. Kreisig, I think we have another giant tear." I said, "My God, another giant tear. This poor patient." Giant tear is mostly a young patient. I looked in, I said, "Doctor, look careful. The retina is attached. Is it a giant tear detachment?" "No." "What is it?" I don't. Let me see whether I can make it. There is only a little hole at the area of the posterior edge of the giant tear. "It is a small hole, doctor." And he said, "Oh, a staph hole, vitrectomy." Look at the contour, the retina tells you. It is convex. What does it mean? Only this little hole has to be closed. That's all. No vitrectomy? Let's wait. Let's close the break and let's see how it develops. The retina attached without drainage. The staph hole got more or less drier, and the retina was attached. And the reoperation was only a small radial buckle to treat this local leakage of the giant tear. It was a small tear to be treated. Now let's conclude, and even after what we listened to already, extraocular segmental buckling is something, a minimal procedure, and when I say to you, not many complications, there is Linkoff, who tries to help you to think logic. He made a meta-analysis of over 2,000 detachments treated, and he found out that the postoperative PVR after local segmental buckling, inclusive balloon operation, PVR postoperatively is only 0.9%, very small. Now, the second thought for reoperation could be the people who like pneumatic or primary vitrectomy. Let's do a primary vitrectomy. It's not convincing, we convinced you with many thoughts, in particular what Thorsten Böker told you, his thinking and reasoning. Linkoff went to facts. He went meta-analysis, almost 2,000 patients treated. And he found out that after a primary vitrectomy, PVR, originally in the beginning it was 24.5%, being now much, much, much less. Vitrectomy is getting better, the surgeons are getting better. However, still today, it's 5.3% PVR. It's 6 times more than after minimal segmental buckling without range. And in addition, if a patient has still the lens, the patient gets a cataract. Perhaps better is traumatic retinopathy. You just go with a needle in the eye. To convince you, Linkoff made again a large meta-analysis of pneumatic retinopathy. And postoperative PVR, now hold yourself at the chair, is 6.5%. It's much, much more than after vitrectomy. And in addition, no breaks. Now, what to do? Conclusion 2, I'm addressing everybody of you, independent which continent, which country you are coming from. The first operation you select when you treat a primary detachment determines the future for your eye, for your patient. And please take time to think, not to think of surgery right away, to think what is a minimal approach always when you treat a primary detachment, and be aware of this. Afterwards, the patient lives with your results many, many years, decades. Thank you for your attention. Here are the rules, and the Congress was so polite to make them in plastic, in DIN A4 size, that you can put it in your doctor pocket, and you have the rules, if you don't know them by heart, all the time at hand.
One question to the auditorium. In this wonderful case with the, I'll show you, with the encircled band, 4 operations, and the whole anterior retina was detached. Who of you thinks that in most of our clinics we will have a vitrectomy, 360-degree retinectomy?
We should throw the patient.
Look at the hands. Look at the hands. So, but you can treat that if you find the reason, the logical approach. Yeah, if you find the logical approach, you don't have to do maximal surgery.
No general anesthesia. You can do it local anesthesia. If you have a balloon, even in topical.
Yes.
Very good. More questions. Daniela has questions.
Daniela, please.
360 retinectomy for is too much.
I want to be provocative here.
It's too much. With heavy silicone oil and laser and whatever. No, just a comment. The question is, besides giant retinal tear, macula hole, strong PVR, do you believe that there are other retinal detachments cannot be treated by episcleral surgery? No answer means that what? Are there any other type of retinal detachment we can't treat with episcleral buckle?
So there is...
If there's a break that does not fit on 2 7x5 sponges, then I think in most of our hands, a vitrectomy would be better. There are some surgeons who even can treat such large breaks with the buckle. Large break that does not fit on a 7.5 sponge. Two. Well, but nowadays, you're familiar with 7.5. Most of them have not ever heard that you can place 2 7.5 side by side and cover a break of more than 1 centimeter width.
So this is similar to giant tear, maybe large tear.
Other pathology, but a large tear.
Let us just be realistic. How often do you have such a large tear?
Rare.
1% perhaps. So you treat 99%.
You're right.
So I think with the advent of vitrectomy, the one thing that I wanted to know was that sometimes you would have a primary, a single break detachment, but there would be slight amount of vitreous hemorrhage, so which would be bothering the patient because of being in front of the macula. So that kind of becomes an issue with going in for a primary vitrectomy. So would you suggest ambulatory patching or something to get rid of that heme and still go ahead with the buckle, or would you still go ahead?
If you have a vitreal hemorrhage?
Very less vitreous hemorrhage.
Okay, well, binocular patching, you have already told. And if you see perfectly the break, you can do the buckle, despite of the hemorrhage, because it will reabsorb. But I'm very curious, so raise your hand. Who is convinced that there are other types of retinal detachment require vitrectomy instead of buckle?
Jörg. So tell us
one over there, just one. So we convince all the audience that we can do buckle in every kind of retinal detachment.
At least in a majority.
Yeah. No, but that guy, would you like to add something?
Not precise.
No, well, it's not precise because it's different for each of you. So I have friends who do 30-40% sponges. I do close to 70-80% sponges of all the detachment cases coming to me. And you probably would do 99%. Yeah. So it depends on what you can do. You have to analyze your results. It's nice to see that one can be as good as you are, but if you are not as good as Ingrid, and I'm not as good as Ingrid, then but not as good.
Right, good enough.
So I still should then do 10 or 15% of vitrectomies when I'm better in that.
I have to add something to this to make it more substantial and logic for you. Forgive me. If you do not count your surgeries, you don't count. So if you don't do your own statistics, you can say, my vitrectomy, I'm better. Count every case, follow up several years, and then you know the truth about your surgery, about your boasting, about your modesty, about your perfection. And that was with me. I followed up every patient for many years, and then I learned to get better in minimal surgery. So please count your surgery afterwards, otherwise you do not count.
The patient needs your numbers, not Ingrid's numbers, not Stanley Cheng's numbers, not Tano's numbers. It's regardless what we do. The patient's operated by you, and you have to be honest about your results if you talk to the patient.
There's a question there.
Yeah, it's just a comment. It's great all that you're teaching, but maybe we have not received, I'm old enough, but even at that, I have not received enough formation to do the buckles properly, to put the sponges properly, to explore the patients perfectly. And even now, even the younger doctors, they are not used to use the indirect ophthalmoscope. Every time we use more wide field, and if you don't see this tear there, you just go to surgery. So it's kind of, we're moving on into a worse procedures for these patients. And also there's an economic reason also, because people prefer to do vitrectomies. They're faster, you earn more money doing them, less controls. So I agree with everything, but...
Basically, they are not faster. The vitrectomy is not faster. A single break detachment, if you're experienced, and I'm pretty fast at it, it's 12 minutes. I don't do a thorough vitrectomy in 12 minutes. Nobody is interested in time, but time is not the point. The problem is that you get much more money for a vitrectomy than for a sponge. That's a problem.
And our formation also.
No,
young doctors are not learning to do this.
I just would like to go a little further. If you do just treat the break, you study more the patient, you have to think more. The thinking, I hope you do this still, the thinking is not paid by the insurance.
Exactly.
It does not make money. Now the thinking is the most expensive what we doctors with a Hippocratic oath can provide. And we are abused by the insurances.
I know.
And for the government
I totally agree.
to cover our hospital. It's up to us to say, We are thinkers, and we think about what not to do surgery. We don't like to do surgery to get better and better surgeons. No, better thinkers.
Okay, I provoke a good discussion, please.
Just one.
I think there is one reason not to do buccal surgery, is the pseudophakic eye, because the pathological things is different, traction, and you can very easily to do a vitrectomy gas injection. The retina is flat. A single hole situation, myopic young patient, of course, buccal must be done in these cases.
Well, again, that depends on your experience. I did about 60–70% of my pseudophakic detachment with a sponge. So the truth is in between and in your hands. One final remark to the binocular indirect.
So,
from India.
Yes. So, you know, the one comment that was raised, that people are not familiar with binocular indirect ophthalmoscopy. There is no get around to this. No instrument currently available covers 360 degree of the retina, and you will miss breaks if you rely on wide field imaging. And forget about retinal detachment. Even for other retinal conditions, if you do not know how to do indirect ophthalmoscopy properly, you are going to make decisions based on limited information or wrong information sometimes, and create trouble for yourself. Even if you are a vitrectomist and if you do most of your surgeries by vitrectomy, you need to do very good indirect ophthalmoscopy, know exactly what you're getting into, and then go ahead and do a surgery.
Excellent. Thank you very much. So, thank you very much. Now I call Darius to the chair here. He's a recent addition to our detachment family. From India as well. And he will talk to us about how to minimize the risk of PVR.
Good afternoon, everyone. I'd like to thank Professor Kreisig for adding me as part of this family. And thanks to her now, I'm a big fan of buckles. But from maximum buckling, I've gone on to minimal buckling. I never used to believe in minimal buckling. After this course and teaching, I've started doing minimal buckling, and it works. For all of you, it works. To believe. So let's talk about the biggest enemy in the room. PVR. The incidence is 5 to 10% of detachment, and it causes 75% of all primary failures. It's characterized by growth and migration of preretinal or subretinal membranes. So we are told that not to use 5-letter words, but there's a 12-letter word which is our enemy, and that is inflammation. Everything I'm going to talk to you now is about inflammation, which is the main culprit in surgery. And this is where minimal surgery works. The less you do stuff, less is more. Less you do, the less inflammation you get, the better results you get. So I think every point which I'm going to say has already been repeated before. No drainage. Don't upset the blood-retinal barrier. No gas injection, because why do you want to make an extraocular procedure, an intraocular procedure? Stay outside the eye. Don't incite inflammation. Cryotherapy. Professor Kreisig said, be like a Girl Scout or like a Boy Scout. Make a beautiful drawing before, so that on the table, you're not pushing and trying to find the break. So this is a total no-no, the diagnostic cryo. Do cryo precise at the area of the break. Do not indent too much, because that's one of the causes for pigment release and PVR forming. And most importantly, limit the buccal to the area of the break. You don't need extensive, if you have a single break or 2 breaks in the same meridian, we don't need that encirclage. And lastly, avoid choroidals, because this is something, if you drain, you get choroidals, then like Dr. Abhishek showed, you're doomed. This is part of the meta-analysis, which I think Professor Kreisig also showed us, and see what the difference in the figures is in the intraocular and extraocular. The reop and the PVR, it's 6 times higher in any case where you go inside the eye versus where you stay outside the eye. So these figures speak for themselves, and these are meta-analyses done over thousands and thousands of patients. So like Professor Kreisig said, see your data. Don't just say my experience. Look at your cases and see the data and see what actually matters. So I would just like to conclude. It's a very short presentation, but the message has to be very clear. The more you go inside, the more reoperation, more PVR, less is always more. And that's what I've learned from Dr. Kreisig. I want to thank her for that. Thank you.
I think Thank you so very much that you keep this in mind and even put the slide on. You are convincing, Doctor. You are a marvelous addition to our course.
Thank you.
Now, you take the questions. You are the expert.
Who believes in pharmacological treatment of PVR?
Yes, I had put that in, but Dr. Kreisig said we should leave it for discussion. Methotrexate and steroids. Anybody has any questions on anything else? I think we have one question.
In the buccal surgery, I do not prophylactic pharmacotherapy, but during the vitrectomy, every time I get triamcinolone in the eye, and the PVR rate after this is much more lower than without steroid. Yes, but in buccal surgery, not. Yeah. So I think it's my talk. Thank you very much, Ingrid, for inviting here in this meeting. Excellent in Paris. I think the third time now here in Paris, and 140 in the rest of the world. So thank you very much also for the auditorium that you are here with so much people. I think over 200 nearly. Yeah? Good. So can I start with my talk? The problem is, must I press something here?
Can you switch?
Yes,
now.
okay.
There to switch.
We see the biggest enemy of the retina surgeon is the PVR. But what do you do if the PVR is still in place if you begin with your surgeon? And Ingrid Kreisig have here an excellent study done, I think, nearly 30 years ago with Harvey Linkoff in New York and in Tübingen. And here you see a simple situation. You place a buckle, the hole is closed, and the retina is flat, and the patient and the doctor are happy. But what is if you have PVR present in time, if you see the patient the first time? And do minimal surgery without cerclage, vitrectomy, also can have a reattachment of the retina in stage B or C PVR. And what's about the long-term results? And is there a possibility that the PVR regressed after a buccal surgery? And what's about the long-term result, visual acuity and redetachment? So you see here 50 patients have C1, C2, C3. That means star falls in 1, 2, or 3 quadrants. And stage B, it means cells in the vitreous cave. The operation was only cryo, segmental buccal, no cerclage, no drainage, no steroids. And the follow-up goes up to over 13 years. Here you see a typical situation. I think the most of the retina surgeons I recognize now, they will do a vitrectomy because they want to peel off the membranes in the inferior part. But it is necessary, it's a question. You see, the reason for the detachment is the hole in the 2 o'clock position. You do a buccal, and in the next 2 months, the retina and the macula are flat, and the PVR in the inferior part regressed. There is still a detachment, but it's a failure? No. It's only traction, and it's gone over the time. You see here 5 months on the right, and 1 year, the detachment is completely resorbed. It's a late resorption. It's caused by the traction of the star folds. So after the first operation, Ingrid Kreisig has redetachment nearly up to 80%, and partial attached in 15%, and still attached in 6%. So what is the reason that the retina is not flat in all these cases? The PVR increased in 6 cases, and you find another hole or an overlooked hole or inadequate buccal in 8%, in 8 patients. So after a reoperation with a radial buccal or with a temporal buccal by balloon, catgut cerclage, or gas injection, 6 reoperation, you can fix the retina for 3 more, and the total attachment after primary and reoperation, it's over 85%. The partial attached the sixth patient, you can still wait. Maybe the PVR regressed and the retina comes up or getting flat in the future. The detached eye, the four eyes, of course, you must do a reoperation, mainly a vitrectomy, maybe with gas or maybe with silicone oil. So what is with the long-term results? So if you have a redetachment, mainly you have it in the first 6 months, and this was by 6 patients. It was 88.3%. And after reoperation, 3 of the patient was reattached. And after 6 months and 9 years, no one of this group have a redetachment occurred in this study. But a very, very late redetachment occurs between 9 years and 13 years. It was 2 patients, and maybe they would be vitrectomized because there was severe PVR occurred. So delayed resorption of the retina, the subretinal fluid, comes up if you have star folds, C1 or C2. You see it's lead longer time that the retina is flat than only if you have only cells in the vitreous cave. So you must think about it. Here you see a typical case, a buccal surgery in PVR detachment, and after 2 months, the macular area is flat and the retina has small star folds in 2 quadrants, but it regressed over the time without any additional steroids. Here you see another case. A buccal was placed, but it was not in the right place. There was an anterior hole at the 9 o'clock position, and after a balloon was placed, laser coagulation was done, the retina in this area was flat, and the PVR is regressed over the time of 4 years, and the visual acuity was very good. What's about the visual acuity after 6 months? You see also patient has a preoperative vision of hand movement. It means that the macular area is detached. It's not necessary to have the macular area immediately by vitrectomy attached. You can do it with a buccal surgery, and mostly of the patient has a reading vision after this kind of surgery. And also in the group of the control 7.5 years ago, the visual acuity was nearly the same as you have it 6 months before, or in the 6-month control. So if you see star folds, it's not mean immediately to do a vitrectomy. Be gentle with manipulation of the eye, do less surgery, do less cryotherapy, and avoid drainage. Therefore, you can treat also PVR detachment with a buccal surgery. Thank you very much.
So, any questions to PVR?
Stefan, no question. Yeah.
Just one comment that this is a macular PVR.
Yeah.
So just one comment that if it is macular PVR, then you may want to go for vitrectomy earlier. But if it is not near the break and not near the macula, then PVR really doesn't count, when you're considering surgery.
I think actually Stanley Chang made a comparison of the massive epiretinal membranes following retinal detachment surgery, and his visual outcome was not better than your PVR cases. So it always depends. Of course, vitrectomy has evolved and has become less traumatic. But again, doing a peeling on a attached retina is much easier than doing a peeling and doing everything at once. So now we come to another tradition of this course, which is the group photo. We have the photograph in the back. He will come up to the front. We need you to pick up a few chairs to put them here together, and then come please all together to get a nice group picture to add to the collection of Ingrid's now 140. So we close the parade.
I think from the back and just
Gefliegt.
Otherwise, if you could please be standing right behind all of the other ones.
You want me to?
Yeah, exactly.
Oops, excuse me. We help. Get everything done.
Oh my God, okay.
Ist das hier gut oder wo wollen Sie No, me. No, we had the first call. Natasha is working in the back, is getting everybody together.
Right?
Please just join us, come in. So, please, Daniele, Stefan.
Yeah, please move ahead. Can everybody move ahead a little bit, please?
But he's in the projection, yes. Okay, we close.
Was ist?
Schwarz ja, die wird ausgemacht.
Natasha, can
I'm not sure.
Which one? Every because there's the half was on.
No. Chairs, there are open chairs, please.
Oh, you want the light? You don't want the light?
I want the light. I want the light. Yeah.
Yeah, he wants the light.
Yeah.
Ah, you want the light?
Ah ouais, I wanted the light. Yeah. Okay, I wanted all the
C'est
light.
quoi les gens, tu les veux comment là?
Natasha, why don't you go there?
I'm asking for his, what he wants as photographer's opinion. And this
Architect, you have to come close.
Okay, can we please have the first two rows sitting?
Yeah.
And then all of the other rows would be standing. Et on les amène devant. Here we have some room, if some of you can be moving a little bit forward. Sorry, I'm looking at you, but and someone can just move forward over here. For example, those three standing gentlemen over there, could you move here and sit here? Thanks a lot.
You have to check with you up.
Die soll in die Stuhl rein, nicht dann nur in die Richtung.
Sorry. Yeah, please.
Thank you so much.
Is everybody ready?
Please squeeze in together as much as possible.
Yeah.
Please go.
Go on podium, people hear you better.
They hear me, don't worry.
I'm afraid.
All right, please squeeze in and smile.
Microphone.
That's fine, they can hear me just well.
1, 2, 3. Okay, again. One more. 1, 2, 3.
Silent camera.
Everybody's
Yeah, excuse me.
That's better.
Okay. Now I make the one.
Yes.
1, 2, 3. Okay, and the last one. 1, 2, 3. Okay, thank you very much.
Perfect, thank you.
Natasha, please announce that now we have coffee in the room.
And yes, there is a coffee break behind you at the back of the room if you wish to grab a coffee or a small snack. And don't forget, the session is not over.
Thank you for that. She'll get the
It's a team effort. Team Yes.
Really? Yeah, he calls me when I'm
immediately should turn around.
So I could. Very good.
You're welcome. I tried. Hopefully the picture looks good.
Unless there is too much PVR. See, there are two reasons to go inside the eye. One is PVR at the maximum. Right? Two is PVR around the brain. Right? Or three, massive subretinal glasses that is not going to, again near the brain, which is not going to, near the brain. So it won't, it will keep the brain tended away.
You don't ever just put a band around and they do the correctly and oil.
That's what he's saying. Huh?
Do you do that often or almost never?
That's what he's saying.
Your success rate will go very high with that. And there's a case study data from the UNPR. Just look at the case
No, no.
Does it work again?
Perché non ci sediamo più avanti? Almeno segniamoci qua davanti. النص الاول من الحكي.
Okay. No way. What is happening? Who's doing this?
So I don't see any tags, I don't see any missed calls, I don't see any fake, this is not how it works.
At least they should tell you.
Just in the morning, they made us and they didn't tell me. So I was doing cables here, I was from all 3 doors, just 300 people came in. And I was doing the same.
Hallo.
They told me,
Ich wollte nur fragen, was ist eine diagnostische Krümmung?
and they were here the whole time. The full room. My guys, can you let me know the next time, please? Yeah, just look at the table.
Doch hat oder nicht? Sag mal so.
Friesen ist es ja oft so schön, das
Das
hat ja
sieht
jeder
man
schon mal
sich-
erlebt.
ja, ja,
Dann
das
hängt
sieht man
man
sich-
nicht.
Not that much quicker.
Yes.
Also die diagnostische Kühe, die war wirklich sind.
Okay.
Gucken wir sich,
Ja,
dann hat sie
ja.
mal was genommen. Das hat sie in der Klinik.
Ja.
Mittlere Straße.
Ja, ja. Genau, genau. Der Jordan Dölliger. Ich habe jetzt gerade begonnen mit dem
Ah, schön. Ja, das sind ja nette Kollegen. Ne?
Ja, sind sehr nett.
Der
Also,
Canisso und der
Nikolas. Ja, das sind sehr nett. Ja. Und machen halt auch noch viel Backellauf und so. Machen auch noch viel Backelchirurgie. Halt,
Der Canisso hat ja einen tollen Vortrag mal gehalten über Kling. Das hat mal einen ganz tollen Vortrag
Ja,
gehabt.
ja, den habe ich halt schon mal gesehen.
Wir überblicken, wir machen. Das eine hilft auch beim anderen. Das ist das, was der Carsten, der Ding gesagt hat. Wenn du dektamierst und selten, dass man kein Loch findet. Wenn man aber wirklich keins findet, du suchst und findest keinen, du machst da wieder. Und dann suchst du, aber dort findest du es dann. Und dann ist es schon hilfreich, dass man die Zeit hat. Was auch wahrscheinlich ist.
Und untersuchen Sie im Liegen wirklich? Selten.
Dann, wenn etwas unklar ist.
Ja,
Unklar
auf dem
ist, mach
Sonnenbahn und dann wirklich auch mit Kopf drehen
ja,
und
zur Sicherheit kann man das machen.
Ja.
Aber so in der Routine nicht.
Patching.
Patching mache ich sehr gerne.
Ja.
Ich habe da mal eine Studie gemacht mit OCT. Bei Patching denken alle, oh, die alten Dinge, die haben ja gar keine Ahnung, so für Tisch und operieren.
Ja.
Ich war gezwungen, ich bin in der österreichischen Kommission für Sachen. Und dann ging es darum in Österreich, dass man gesagt hat, jetzt geben wir so ein Paper oder etwas hinaus, Empfehlung, Ablatio muss man am gleichen Tag operieren. Da habe ich gesagt, ihr seid ja verrückt. Wollt ihr, dass ich 365 Tage jede Nacht drin sitze und operiere, am nächsten Tag um 7 Uhr weiter operiere? Das ist ja völlig verrückt. Im AK in Wien ist es halt so, dass immer einer Dienst Tag machen, er schläft und macht nichts, dann schickt, dann habe ich gesagt, für das gibt es keine Regel. Nur, dass ihr in Wien nicht zum Organisieren kriegt, dass der Dienst haben ja auch operiert. Kann nicht die Regeln für ganz Österreich. Dann habe ich gesagt, bei mir ist es egal, macht die Leitlinien, wenn ihr wollt. Ich mache Double Patching. Jeder OCT vorne, Double Patching. Am nächsten oder übernächsten Tag, wenn ich ihn operiere, dass ich in der Nacht nicht aufstehen muss. Oder wenn ein anderer Arzt, die ich jetzt eingeschult habe, wenn die in der Nacht operieren, am nächsten Tag kommen die nicht mehr. Den ganzen Tag nicht mehr zur Arbeit, wenn wir in der Nacht eine OP machen. Da habe ich gesagt, gut, mach, schauen wir, das ist eine schöne Studie mit OCT. Also wird ja weniger.
Ja.
Die haben ja gesagt, oh, Makula offen, Risk of Makula offen, muss man sofort operieren. Keine, wo Makula offen gewesen ist am nächsten.
machen Sie stationär dann, also nehmen Sie so einen stationär auf, nehme ich an, oder? Oder schicken Sie nach Hause und sagen,
funktioniert
Sie
auch.
brauchen irgendjemand, der sich dann um die kümmert.
Aber jemand, der Ablatio hat, der hat ja Panik. Der hat gelassen und sagt, du musst sofort nach Hause schicken. Das ist ja nicht, weil dann sagt man, ich habe mich nicht ernst genommen.
Ja, weil die Leute haben das schon in den Köpfen, so dass das jetzt möglichst rasch
mit jemandem mit fast blind nach Hause nehme ich auf und ich organisiere am nächsten Tag. Dann kann die Narkose das machen, das kann die Aufnahme fertig machen. Wenn ich habe am nächsten Tag eine OCT-Aufnahme, Double Patching gemacht, da telefonieren, ist das gleich, ist ein bisschen weniger, machen wir es darüber. Der Patient sagen, wir wissen Sie, wenn der Ablatio schon weniger ist, dann ist das zum
Parallaxe ist deutlich einfacher. Und nochmal von der Indentation her haben Sie gesagt, von peripher kommen, aber das Bild war wie, da war die Indentation von posterior her nach oben kommen.
Ja, genau. Dann ist man natürlich Bild, das legt sich an, dann macht man den Punkt so weit zentral.
To lose time.
Okay.
Where are the speakers? Where is the program?
Aber beim Einwählen, also eins.
Nice to meet him. We are here
So, perfect.
Ready?
Ready. We start. Thank you. Excellent work. We have to start again, otherwise we cannot show any video. Yes. So, please everybody come back to the chairs, otherwise we have not enough time for the videos later on.
Ja, spannend.
Everybody wants to see moving pictures.
Ja, wo?
Okay.
Aber Professor Kein.
Please come to the front.
Noch gehört, aber ja. Der war
Mich fest unterstützt.
Ja.
Ich bin immer zu ihm gefahren.
Ja.
Wenn ich Freitag frei hatte, war ich am Morgen um 5 Uhr im Auto.
So,
Ja, okay, verrückt. Ja.
again,
Basel, dann kennen Sie es gut. Ja.
please come to the front. Dann muss ich das so machen. So, very good. So we start the second and last session. And Ingrid pointed it out that there's an even less invasive procedure. And I call you, Ingrid, now to present us the Linkoff-Kreisig balloon procedure. I close that. Please.
Can we start? Is it possible?
Ich ändere das ein bisschen nach unten und dann.
All right.
Okay.
Not too loud and not.
Perfect.
Where is the laser pointer? Let me
Laser
see.
pointer is there. If you.
Yeah, now it works. Now, we are talking about a procedure, you will not believe it, which is even less invasive, less traumatic than minimal segmental buckling without drainage. And this is something Dr. Linkoff and we did 8 years animal experiments. And I took 3 years in Tübingen, where I was working there, to get a balloon which is good for practical use to do this procedure. To be truthful, in my opinion, it is an ultimate minimal extraocular approach to treat a retinal detachment. Now, here we have a detachment of 3 quadrants from 8, from 4/6 to 12 o'clock, a hole at 11 o'clock, perfect. Now, should we treat it with a cerclage? Should we treat it with Is there something we've forgot to do? Okay, let's continue. What is more difficult with a balloon procedure until we did already segmental buckling without drainage? Minimal segmental buckling without drainage, what is there very difficult? To localize a detached break. If this is already difficult for you, and I always said you must have done at least 50 cases non-drainage segmental buckling until you move towards the balloon operation. Why is the balloon operation even more difficult? Because you have to localize the break on mobile conjunctiva. And what is there the problem? The parallax in circumferential direction and in radial direction. How to circumvent this? The circumferential parallaxis you can circumvent if a hole is at 11 o'clock, as you just saw in this detachment. You put the cornea in horizontal position and you go exactly across for looking in the eye at 5 o'clock. And how do you circumvent the radial parallaxis? You remember, you don't open the conjunctiva. If you move with your cryoprobe on the mobile conjunctiva, you move the conjunctiva in every direction. It's mobile, and your mark is not okay. So you start to avoid radial parallaxis with the depressor, with the cryoprobe at the ora serrata, and go straight radial. Now let's look. What is special and new with the balloon operation? You don't have to do an episcleral suture, and you know if the sclera is thin, myopic eye, and anyway it's difficult, you can perforate. And what's in addition very favorable with the balloon operation, the buckle is removed after 1 week. And after 1 week, when it's removed, you don't have to open conjunctiva. You just put a syringe on the adapter. You will see it's fixated at the front. Take out the fluid, and spontaneously the catheter jumps out of the conjunctiva. That means if you remove the balloon after 1 week, you don't have, and you avoid the last complications of minimal segmental buckling with the sutured sponge. You don't have diplopia, and you cannot have buccal infection. Now, how do you do this? You have here an eye on the left side. You localize the hole 15 millimeters from the lifters, and in the radian, you do as well 2 more spots that you know in which radian the balloon has to be moved to be in the radial direction. And then you open conjunctiva for 1 millimeter and insert the balloon. And these little marks you see here, these black marks, they show you this is 10 millimeters from the center of the balloon and this 50 millimeters. So when you have inserted the balloon, you know how posteriorly the balloon is located. After surgery, you fixate the catheter on one side of the nose, and the adapter you fixate on the front of the patient. At the end of the surgery, the same as with non-drainage segmental buckling, the retina is still detached, and the balloon is this time fixated between the bony orbit and the sclera. There is not yet a deep indentation because the eye pressure is already elevated. It cannot indent very much. So be careful not to move around the balloon. And here is now a movie I did together with a co-worker at that time from Poznan. You see we are intercontinents, inter-countries. Here, this detachment hole at 11 o'clock. We localize on conjunctiva unopened. We make a mark. As I told you, the hole is here. And then we make in the radian 2 more marks that we know in which radian we have to move the balloon catheter to end up at this place. The retina is detached. We measure 40 millimeters, and now I show you we inflate the balloon. At surgery, it's only compressed between the bony orbit and the sclera. We open conjunctiva now 1 millimeter at around 7 millimeters anterior to the mark in conjunctiva. Here the balloon. You see here, this mark is 10 millimeters from the center of the balloon and this 50 millimeter. So the second mark has to be at the limbus when the balloon is 50 millimeters posterior of the limbus. Now, the catheter is like an overcooked spaghetti, very mobile, flexible. We insert a metal stylet that we can guide the balloon in the direction we want to move it. We measure from the center of the balloon 50 millimeters. The second black mark has to be at the limbus. Then we know the balloon, which we now inflate, will be 50 millimeters posteriorly to the limbus. We take out the stylet, and now we insert the catheter with a syringe with sterile water and inject at first 0.5 milliliter of fluid. What do we have to do? We see whether the central artery is pulsating. We check. Central artery is pulsating. The balloon we hardly can recognize. We inject to 1 millimeter, so the balloon has a diameter almost of 12 millimeter. Here is an animation. During surgery, you hardly can recognize the balloon, hopefully correctly positioned, beneath the detached brake. We take the syringe off. The adapter keeps the fluid, and now that's the end of the surgery. You have now to be very careful we suture the muscles to know where the balloon has to go. If you do topical anesthesia, the patient looks in direction you want to have him. You have to be very careful when you take out the speculum that you don't displace the balloon because it's still not fixated. As I mentioned to you earlier, you fixate the catheter at the side of the nose and the adapter at the front, and if the next morning you want a larger buckle, you just inject via the adapter a little bit of fluid and you have a larger balloon buckle without operation. What do? We use here Medretic, you can use antibiotic or bepanthen, and we double patch after surgery because the balloon still does not make a very deep indentation, and therefore we have double patchment until the next morning, and if the retina is attached, we just have a patch over the balloon area. The patient just wants to say goodbye, have a nice time in Paris. This is after surgery. You see the balloon buckle and one cryo lesion, and the next day we add laser lesions. After 7 days, the lesions are pigmented. We pull out the balloon, we just take out the fluid. As I mentioned before, it jumps out by itself. Now, that is after surgery. As with segmented buckle, the retina is detached. Hopefully the balloon is in a correct position. The next day we see the deep indentation with a cryo mark. We add laser lesions, and here you see now the balloon is no longer compressed between the bony orbit and the sclera. The retina is following. The eye pressure got normal, reduced the high pressure to normal. The compressed balloon, silicone, expands, hopefully makes an indentation in the correct buckle. The balloon buckle has to be correctly positioned beneath the brake. And now, here is something what was not perfectly well done. The horseshoe tear was not nicely surrounded with cryolesion, and there was a detachment. In our regiment, we did not do another balloon. You could have done a balloon. The regimen was, in our series of 500 patients we did consecutively, we had to do a sponge as reoperation. Now, you say, when can I use a balloon? You can use a balloon if there's one break. Remember, 50% of detachments, there's only one break. Or there is a group of break within 1 clock hour. This you can treat with a balloon. And now when should you start with segmented buckling without drainage or with a balloon operation? Take a small detachment. The parallax is not very big, and there is much detached retina also not present to overlook a break. The localization is easy, and you see, you add to the cryolesions laser marks. After 1 day, it looks like this, and after 7 days, the lesion were pigmented. That means the scar is strong enough, the balloon was removed. And when the next day, the patient goes back to his doctor who sent him to the hospital, the doctor says, my God, you didn't have a detachment operation. You just have a horseshoe tear treated with coagulations. No, doctor, there was a buckle, there was a balloon buckle, and it was removed after 1 week. My God! And that's possible. Yes, that was it. Now another detachment. It's more work. Is it now vitrectomy? No, you know, convex contours, there is a break. But this is a more difficult case. There are more chances you overlook a break. And of course, the break is more highly detached. The treatment is the same. It was minimal segmented buckling, also for balloon operation. Treat the buckle. Afterwards, the hole was surrounded with cryolesions. This is a good indication. It is a patient which has full vision on both eyes, mostly not very grateful patient if you are ending up a patient with diplopia. The buckle should go at 9 o'clock where you have the rectus muscle, diplopia, my God, what to do? We have a balloon. We treated it, and as long as the balloon is in place, of course the patient has diplopia. You see on the right-hand side. But if the balloon is removed, and there are only coagulations around the break, no diplopia, the patient is very happy, macular vision, happy patient. And now you would say, how are the results? There are 500 consecutive patients being operated with me and my staff, 500 cases consecutive. We decided to do a balloon. There even had been reoperations among these patients. After one balloon operation, the retina was attached in 91%. Follow-up 6 months, 2% detached. After one reoperation, the retina was attached in 98%, and listen, only in 4 eyes or in 0.8%, a second reoperation was needed. And the retina was attached 99%. Of course, it is a selected group of patients, one break or a group of break between 1 clock hour. But in the follow-up of 3 years, no redetachment. But we explained the patient, what I explained to you, to use passive prophylaxis to detect in time if there is a detachment developing. Now, what are the complications with the balloon? If you don't do very much, you cannot have many complications, practically none. And after the balloon is removed, you even don't have diplopia. What are the advantages to think about? A minimal surgical trauma. It's done very quickly. You can do it in topical anesthesia. You don't have intraocular complications because you don't enter the eye. You don't make a scleral sutures. You cannot perforate. You don't have extraocular complications. You might have less than 1% with minimal segmental buckling. Diplopia, no buccal infection. You can do it in topical anesthesia or parabulbar. You don't have cosmetic defects. What's important? A very rapid recovery of visual function. That's a minimal approach to reattach a retina. Are there discussions? Where is Stefan? Could you just come? No questions? All right. Does the audience, do the speakers have questions? I'm sure Torsten always has questions.
Well, it's not a question, it's a regret. It's unfortunate that in the times of maximum cost ratio benefits, the companies are not providing us with the buckle the balloon buckle anymore.
Yeah.
Nobody is willing to just produce it because we don't sell 100,000 a year, you know. We don't need 100,000 a year, so we don't have it right now. Otherwise, it would be a very nice option. But if they do 1,000 a year, we had to spend probably 2,000 bucks for one catheter, you know.
But I wanted to implant in your mind, here is very much the young generation, the upcoming retina surgeons. Keep in mind that is possible. We just have to aim for it. And Dr. Linkhoff and I, we worked many, many years on animal experiments. That's not needed. We know how a balloon has to be produced. And if you do minimal segmental buckling without drainage, you even could switch because you know how to localize a detached break. That's something to reassure all of us. More questions? Stefan. All right, then we continue to the next.
Yeah. I've done in 89, 90, 91, I've done a few balloon buckles. A very nice procedure, but
Vincenzo did.
Very nice procedure, isn't it? Yeah. So, Now we ran with you through all the different techniques, trying to emphasize that less is more. And we have a few pictures here of some of the protagonists, and we are glad to have Ingrid here. So the philosophy, we talked about it. A rhegmatogenous retinal detachment is caused by retinal tear. Keep that in mind. No tear, no break, no rhegmatogenous detachment. This may be caused by vitreous traction, yes, but vitreous traction alone is not something we need to treat. So still we see nowadays surgery of the retinal detachment, which can be surgery of the retinal tear, like we propose, surgery of the vitreous, and we just saw this balloon buckle. This is a proof of principle that just closing a break for a week so a scar can form is sufficient. So just retinopoxy, the temporary closure of the break, it is a perfect example for proof of principle. So what is mandatory also for these techniques, for all techniques, find all breaks. And as we told you, preferably preoperatively. And we showed you what you need to do for that. And Ingrid and Harvey gave us rules to find those breaks and to sort of hone in on our success rates, you know. And then we have to close all the breaks. And in the balloon buckle and the sponge buckle, up external, from the outside. Now, if we talk about pneumatic retinopexy, it's still the same. You have to find all the breaks. You have to close them all. Up internal, though, with the inflammation you cause, with the PVR you cause, but then you can be successful as well. So if you look at the meta-analysis we talked about, then the main difference is the PVR rate between pneumatic and non-drainage buckle. So pneumatic, now it's down to 15% with more and more laser. We talked to this one Canadian group last year in Barcelona who did do 3 to 5 sessions of prophylactic laser after the pneumatic retinopexy to get rid of the risks. I know Abhishek is a friend of selected cases, pneumatic retinopexy, round break superior ones. So there's nothing wrong with it. But keep in mind, if you inject something into the eye, you get inflammation, and you get more inflammation than in a non-drainage buckle. So this is true as well for the vitrectomy. Find all breaks, close all breaks. And if we now look, then we would think that taking away the vitreous, it should be much better than just a pneumatic retinopexy. But if you look at it, it's a little bit better, less reoperations, a little bit less PVR, but it's not down to the numbers you can achieve with non-drainage. There's a proof of principle that just vitrectomy is sufficient. The group around Garcia Arumi did a very nice study. What did they do? They did vitrectomy, reattached the retina with heavy liquids, did a complete fluid air exchange, and then on the air-filled eye, a transscleral diode laser, so very gentle. And then at the end of the surgery, they filled the eye completely with balanced salt solution. So there was no tamponade at the end of surgery, but they did, Hyman, a friend of ours, he flew down and said, I have to see what they do. And they did a very thorough vitrectomy with vitreous base shaving for 1.5 to 2 hours. And then there was no traction. And what did they achieve? They did achieve a reattachment permanently for 59 out of 60 eyes. And the other one need one reoperation. So it is possible to do it up internal, but it's a very thorough procedure. It's difficult. It's a very dedicated surgery. And the amounts are not that much better than we can achieve with a non-drainage buckle. But there still are other questions in buckling versus vitrectomy. There was the SPR study for the moderate complex retinal detachments. They looked at phakic eyes, pseudophakic eyes, with the comparison of primary vitrectomy to sponge operation. And they get very nice, valid numbers on reoperation rate, cataract progression, and so on. And they did not show, they did show a benefit. Even though they wanted to prove that vitrectomy was better, they did show that scleral buckling was better in terms of best visual acuity in phakic eyes. So that's something you should keep in mind, and we come back to that. I did the business of calculating the costs. If you calculate the reoperations, the cataract operations, then in the phakic group, with the pseudo-phakic patients needing vitrectomy, you spend much more money on reattaching the retina for a best corrected visual acuity that was less than in the sponge. So that's not a very good argument. And in the pseudo-phakic group, where you said you should do a vitrectomy right away, they did show that basically there are more reoperations, yes, but still the costs-benefit ratio is the same. So they did not spend more money to achieve the same, and there was no significant difference between best corrected visual acuity in the pseudophakic group. Then if you look at potential complications, that is perforation, choroidals, infections, the balloon has the least potential for complications. A buccal, you place 2 sutures through the sclera. Buccal and drainage, you perforate the eye. Cerclage, you place 4 sutures in each quadrant. Vitrectomy, you enter the eye. Pneumatic retinopexy, you compress the vitreous, you can create new breaks. So that's not scientifically underlined with numbers, but that's the potential for complications. However, best corrected visual acuity. So there are studies, sclerobuckling versus pneumatic retina vitrectomy. So in a prospective multi-center trial, sclerobuckling had +7 lines, vitrectomy only +5 lines, and that was correct for cataract already. In the pneumatic, in the pivot trial, pneumatic retinopexy versus vitrectomy, pneumatic retinopexy achieved +17 letters, vitrectomy +11 letters. So basically, we're talking about a 1 or 2 line difference in the visual acuity between non-drainage buccals and vitrectomy, or pneumatic retinopexy and vitrectomy. Now, what is the reason for this difference in best corrected visual acuity? Most likely the retinal displacement that provides us with new insights. And what actually happens, it came on in the discussion that the forced reapposition of the macula may be a problem, and that the slow reabsorption of the fluid may be better. So the translocation of the retina post-vitrectomy is present in up to 72%. How do you look at the translocation? You take an autofluorescent picture, and this is a post-vitrectomy retinal detachment photo of a patient who had a macular on detachment. And if you now look at these arrows, you can see a very tiny light mark where the vessels of the macula used to be before the surgery. And this is a patient with a macular on detachment. So still the whole retina shifted downwards. You see down there the vessels, and up there the vessels where they were formerly. So that happens. And how frequent does it happen? Hyman took in Liverpool the work and looked at it and compared sclerobuckling and vitrectomy for a year. And he saw that in vitrectomy, you have this macular displacement in up to 6 times the frequency than in sclerobuckling. And of course, it differences between macular on, macular off detachment. But again, keep in mind, 36% at 3 months, 30% at 6 months, and even there in a larger amount. So basically, he ended his talk that I listened to in Münster back then. How far would you go for 2 lines of vision? Would you go and just use a non-drainage buccal, please? Thank you very much. Questions? Comments? Yes?
Microphone, please. And country.
And name.
It's Qatar.
Hashim Abu Sarhan from Qatar.
Yes.
I just have a question coming back to the balloon buckle. Actually, there is one Chinese company in Guangzhou. They made the balloon buckle, foldable capsule buckle, and it's available in the market, in Chinese market.
Okay, so we have to look into that then. The question again is what's the quality and how we can, but thank you very much for this insight. Okay, I think it's time for Stefan again. Yeah, so tell us how to find this dent break during surgery.
The question also we want to point out how to train. How is it possible for the trainers and how to be trained? What is necessary and helpful? The essential skills for minimal buckling, it's the binocular indirect ophthalmoscopy, bio. If you do not know how to do, you are not able to do the surgery. And also episcleral suturing on the sclera is very helpful if you know how to do it, to learn this treatment. And if you look a little bit back, it's already known from everyone, 1850, the first ophthalmoscope by Hermann from Helmholtz, and later it was Charles Capens in 1945 who improved the binocular indirect headband ophthalmoscope, introduced it in France and moved on to United States and introduced it there. And today we already talked about it. We have wide field images, they look good, but do not have the possibility to present and image the parts that are essential for the periphery 360 degree. So what we need to use the binocular ophthalmoscopy, the bio. And it is extremely important for defining the borders, looking for the detachment, finding the breaks, and intraoperatively to localize the breaks. And if we use this instrument, the learning curve, it's a long time. I had to do it for 1 year at home. My head gave me an ophthalmoscope home with a plastic of eye, and he said, you have to train for 1 year. After that, you are allowed to do a retinal cryo without detached retina. So I had to train and train to use this ophthalmoscope. And there are many things, the working distance, pupil size, glare in reflection. You have to learn in many, many cases to be aware and to find the break. And it's the question where to learn it. We use it, but has everyone read it, how to use it, the instruction manual? Go to the homepage of these companies and you will see the manual where everything is described of the bio. And look, there are also videos, how to use it, how to place it, and how to perform it. Make aware of it. Go to the young people, say, look there and train by this. Because I remember I wanted to train buckling treatment to a doctor. He didn't train bio. And he wanted to do it during surgery, and he was not able to see the break. He was not able to find the break. And then he said, I think it's better I will stop because I'm not so much interested. I'm not trained in this bio to do this treatment. And if you look here, you have the headband, the horizontal and the vertical to fixate it very good. Move the optic unit very near to your glasses or to your eyes. And look to the power unit. We have very different ones. Xenon, halogen, LED, and today it's not any necessary. You have for the power unit, it's mostly wireless. And look to all these things, the pupil distance, the filters, the aperture, and the pupil settings that are very important. If you look for the mydriatic patient and you have a wrong pupil size, it's not very good and easy to localize retinal breaks. And look to the distance. A more distance will help for a greater visual field. A shorter distance is for more magnification. And it is helpful also for the trainee and for the teacher. We have this mirror. You see it here. You can look what the young doctor is looking for. You can give him advices how to do it. And we have new also developments. Look here, it's a vision boost for opaque medias, for a better view to the retina in incipients of cataract formation, or the digital ophthalmoscope, where it's helpful to look at the video screen. What is the young doctor is looking for? What can I help him? Or I look with the video and place him, look to this area, so we can help each other. And very interesting, especially for ROP, you know, it's very, very difficult because these babies, they move very much. You have half of a second that you see something of the peripheral retina, and you have to decide whether what is the stage of the disease, do you do to the treatment that is very necessary for these children. And there is a simulator available to try and to perform the bio. And it's what to do in our clinic. We have the bio in every slit lamp examination available for all the doctors. Please use it every day. Then you are it's more comfortable for you, and it should be easy to use a training for every day. And those doctors who do the ROP examination, they are much more easy for them to find the brake and much more easier to use it. So we have the doctor in training, the other doctor with experience to help him, and it's when he is doing and do not find it, we can change all the time, and we had to do it for several times to get more comfortable in this setting. And what we do in our clinic, if we have a patient with retinal ischemia, where we have to do laser treatment, we also can do peripheral cryo. So we can perform peripheral cryo. It's much more easier. Retina is attached. We get more comfortable with the cryoprobe. Or, as you can see here, we have retinal brakes with attached retina. You can train retinal cryopexy. It's much more easier for these cases. But at the beginning, it's also often difficult to see a retinal brake. Then you can start with a laser treatment in the central part of the brake, go in the OR and do the cryo. Then you easily find the brake because due to the laser treatment, and make the cryo on the very peripheral part where there's the most traction of these cases. And the topic parallax, it's very important. The circumferential parallax you can avoid if you look all the time that there is an axis of your eye going through the lens, going directly on the other side where you make the indentation. And if you move your body and your head, you always have, it's the same for the indentation and the same for the lens. It should be one line to avoid the circumferential parallaxis. And what to do against the radial parallaxis? Yes, we already pointed out, start with indentation in the very periphery. If it's a high bullous in the very central retinal brake, we know double patching that the subretinal fluid gets less, so it's much more easier to localize, to perform the indentation and reach the retinal brake, to have a correct marking of the retinal brake at the sclera. So if we look to the essential skills, binocular indirect ophthalmoscopy, you have to train a lot and do it in routine examination, performing ROP cases or do retinal cryo with attached retina to start with and get familiar with. The other point is episcleral suturing. Those doctors in our department who start with minimal buckling treatment, they did treatment of strabism surgery, and I do not tell them how to make sutures in the sclera. They did it for years, so for them it's much more easier to start with this minimal approach. Therefore, doctors with a lot of experience in binocular indirect ophthalmoscopy and doctors with experience in strabism surgery, they are already perfectly prepared for minimal buckling surgery without drainage. Thank you.
Questions? So there was one question in the short coffee break, how to treat, how get the experience. If you are not an experienced binocular indirect ophthalmoscoper, you're out of the game, definitely, like you said. So you have to practice that, you have to be strong at finding everything in the retina, otherwise it will be difficult. You? Is on.
The other thing is that you have to practice with both your hands, holding the 20 diopter lens in both your hands, not just the right hand or the left hand. You have to, because when you move around, depending upon the eye and the quadrant of the brake, sometimes you may have to use the right or the left hand. So you have to be familiar doing the indirect ophthalmoscopy with both the hands.
The nose may be in the way. Okay. So now we start with the video session, and I would like...
You know, I will stress also the role of droning also the vessels, because whatever you see during the examination at the slit lamp quite often disappears when you enter the OR, because you are in a stressful situation, and the visualization is not as good as when you are in a quiet room. So mark any vessel which is close to the tiny hole. It's a way of finding back it.
Drawing and having the patient examined lying down as well before. Now we start, Stefan again, with the...
Starting with the video session, I have brought to you a very simple case, a case where you can start. First, on the...
Sorry?
So first I start with my microscope. I remove the conjunctiva at the quadrant I want to place the mini-pupil buckling. You see the microscope, I remove the conjunctiva. It's a simple case, 2-quadrant detachment. There is a small 1 millimeter break at the temporal superior quadrant. I remove the conjunctiva. I have sutures on the 2 rectus muscle, on the rectus externus and superior. And now at the next point, we mark and look for the retinal break. And as this is a small retinal break, we only make 1 mark. And after that, we go for the cryo, start in the periphery, looking to the area where the break is. Do not over-cryo this. And after performing the cryo, as it is a small break, we took a 4 millimeter sponge. And 4 millimeter sponge, we know mattress suture should be 6 millimeters. And we mark it here and perform a radial sponge. As the detachment is not a high bullous, we perform it with a half of a 4 millimeter sponge. And very important, look to the tip of your needle. All the passage, the bite should be as long as possible. Look at the tip of your needle and try to make it as long as possible. I start 1 or 2 millimeter peripheral and go 1 or 2 millimeters central to the point where the retinal break is. And removing, don't rotate, very gently move it out. I do it on the one side, then the suture on the other side, make a knot here in the peripheral part, as you can see here. I take only a 4 millimeter sponge, I made the half of it, and place it now beneath this knot here, and here the other knot. We make a pressure and make a high pressure to the sponge, because then there's an increase of eye pressure. This decreases over the next hours, with the consequence that the sponge enlarges and the buckle becomes higher. Now with pressure, we suture here this place. And as I told you, it's an easy case because it's between 2 rectus muscles. It doesn't touch any rectus muscle. The sclera is very good to suture, and after that pressure, we go and look into the eye, to the central artery, look if the buckle is on the right position, and after we have performed that, we close the conjunctiva, and the surgery for this case is finished. Thank you very much.
Any questions, comments? Abhishek. Sure. Yeah, there's one question, sorry.
Hello, I'm Jordan from Switzerland. Just, do you ever do anterior chamber puncture? I'm Jordan from Switzerland.
The question was, have you done an anterior puncture to decrease the eye pressure? No, we don't have done it. After we have sutured, it's a small radial buckle, we look inside the eye, we look to the central artery. It was pulsating, there was nothing to do because there was a pulsating central artery, and we do not have to reduce the eye pressure at this time.
Basically, it's an option. I know of colleagues who do it, but again, you change from a completely extraocular to an intraocular procedure. Not with all the risks, but with some risks. Another question? No?
Wojciech from Poland. I have a question. What do you mean by minimal cryo? So when the retina becomes white, that's when you finish, or how long do you stay?
This is already, the question is how strong we should do the cryo. The cryo, if we make the indentation and start with the cryo and it becomes a light whitish, you already should stop. Okay. But thinking that I have to perform cryo through sclera, choroid, subretinal fluid until it reaches, it's too much cryo.
Okay, thank you.
I use the one by Lacqua, others use them by Schwickerath, others. The question was, what type of localizator do we use to mark the location of the break? And there are different parts available. Me personally, I like the Lacqua indenter. It has a small circle, and then you can gently move on the sclera, and if you indent a little bit more, it leaves a black mark, and then you can mark it. You're right. Yeah.
We localize with a cryoprobe. We indent, and since we freeze, we treat already, then we know where it is. I mean, you use a cryoprobe for localization. You save one step of surgery.
Again, if your assistant is good enough, because if the cryo is centrally, and you take it away and he doesn't hold the sutures, then it can be away after a second.
The cryo is done by the surgeon, who controls with ophthalmoscopy.
Yes, that's true, but...
I use a closed forceps, like I think you also use the same, right? The closed forceps, and we indent, it makes the dark mark on the sclera.
Same.
And then we mark it with a Jensen boilet or a pen.
When do you do cryo?
Pardon?
When do you do cryo?
So we do the marking after the cryo.
Well,
you can do it at the same time.
At the same time also, yes.
But there's a lot of discussion. See, I was in the discussion once that if you do the cryo, then you have a choroidal hyperemia afterwards. So best would be to place the sutures before you do the cryo. That's one idea at least, because then if you perforate, you don't do it in the hyperperfused choroid. But again, it's just an idea, I cannot prove that.
Last one question. If you have to put a radial buckle under a muscle, I'm Dr. Tartaro from Italy. Is there a muscle that is more dangerous for diplopia?
Yeah,
for example, vertical.
Diplopia, yes, I think for diplopia, the superior rectus and the inferior rectus, if you put a buckle under these, it causes far more. The chances of causing diplopia are far more than the lateral and the medial recti.
Because you may not look at the oblique muscles.
Yes.
Okay.
Microphone, please. Are the people who should walk around?
What's your habit when you have the break under the muscle? Circumferential, radial, half sponge?
Well, it depends on. If it's a small break and I can get away with the radial buckle, I do the radial buckle, but I don't disinsert the muscle. If it's another tiny break and I can switch on a very short circumferential, then I can place the suture left and right to the muscle insertion. That would be much easier. And Ingrid told us one trick. If it's almost on the muscle insertion, you can even place a sponge just on the muscle insertion. And if you have diplopia, take it away after a week or two. You know?
Let the patient exercise.
Yeah, and then move around. Okay. And after him, did you show the video? Oh, I'm not well dressed. Oh, that's better. Thanks.
Yeah, so this is one of the earlier videos that I made, and I'll show you what you shouldn't do also in this. So this video will start with a little bit of the schematics so everybody understands the sequence of retinal detachment. Now, let's suppose you have a detachment like this. These are the steps. You open the conjunctiva, you mark the break, and then you select and size the buckle, and then you put the suture and close the case. So this is me opening the conjunctiva. This was a superior temporal RD, like I said, superior temporal break. And this is a limited peritomy. You do it only in the quadrant that you want to do. When you're opening these scissors, don't take it too far posterior, because then you can injure the penetrating vessels. We've bridled the both the recti on both sides of the break. You don't need to bridle all the 4 muscles. You then do sharp dissection to create space for yourself and clear away all the tenons, because your sutures should be through the sclera, not through the tenons. Then you do, this is the closed forceps indentation and marking that I've done. So that's the break, and the anterior mark is the ora. Now here I was planning 2 sutures, so I've taken smaller bites. Yeah. Yes, so this is something that we would be discussing about. So this is the anterior bite, and this is the posterior bite. Yeah. So we are showing what should not also be done.
Exactly. We should have bad examples.
Also.
Wir müssen ja auch sagen, was man vermeiden soll. Und er zeigt gleich nochmal.
So we've put the buckle there, and then you kind of tighten it, and your assistant holds the knot when you've tightened it, and then you finalize the knot. And this is pretty much the end of the surgery. Once you've placed the buckle here, then this is the posterior suture being tied in a similar way. And then you close the case. So you suture the tenons and the conjunctiva. Now,
so just to point the short discussion up here in front of us, it would be preferable if you have a long path of your needle through the sclera, not too short bites. They might tear out easier. So pass it through for at least 5, 6, 7 millimeters, so you can do it with one. And now he shows us.
So this is the yawing. So this is the yawing movement of the needle. See, the tip of the needle is always visible. You can see the tip of the needle. This should always be visible. This should be partial thickness. And then you take a reasonably long bite. So this is how it should be done. The same way. Now, what I have done is I've gone the other way around, and now from the posterior to the anterior I'm taking. But if you have a double-armed suture, you can take both the bites going from anterior to posterior, then cut it in, then tie the posterior one and the anterior one separately. With this, you have to tie it only once.
What kind of
So,
suture is that?
this is a polyester suture. This is a 5-0 polyester suture. So this is what you've done. Now here we don't have a knot in the, in the posterior side. Then same thing. You press the sponge, tighten the suture, then your assistant holds the knot for you, and then you finalize this. So this is a temporary knot. Sometimes you may want to do a temporary knot, go inside, confirm the placement of your buckle, and then finalize it. So I've confirmed it, and now I just finalize it by pulling it from the other side. So I think the rest of the steps are almost the same. Thank you.
Thank you very much. Question. There will be a question.
So Abhishek, I think we have a lot of new beginners here, and as we are learning how to take a suture. So my question is that in the beginning, when you're taking these sutures and going from anterior to posterior, what if you have a perforation and you end up with hypotony or a bleed? What do you do next?
I think he has a video on that, right?
I can show you that.
He's going to show you that. So, perforation in an area of detached retina, and you've not caught the retina, and there's just a little bit of SRF drainage, you don't need to you don't need to bother that much. If there is a hemorrhage, then of course, your indirect ophthalmoscopy, check what is happening inside, and then proceed.
Yeah. Another thing is, if you have some loss of subretinal fluid, I would recommend never to drain completely, because we like to have the subretinal fluid around. It will show us the next day whether the sponge is in the right position, yes or no. That will be shown as well.
Nothing to declare. Right, this is a simple case, right for sponge. So MIAP, you see bullous retinal detachment, superior quadrant, one single break, perfect for sponge. And this is video. This is our routine technique, so 360 peritomy, then hooking the recti muscles. And finally, So this is a suture for the muscle. And then finally exposing the quadrant where we have to put. But in this case, we had a surprise. You see, with a lot of scleral thinning, what should we do now? Abandon and go to vitrectomy? No, we decide to continue. So you see the mark of the break with the cauterization. Then we mark the place of sutures. Of course, the sclera is very thin, so the passage of the needle should be very careful. And as we have already heard, we have to control the tip of the needle.
Would you like more the round needle? Microphone, please.
No, I prefer spatula needle because, yes, it's more sharp, but it's flat. So, as Thorsten has already said now, the patch should be as long as possible because sometimes the sclera lacerated. So this is our suture ready for the sponge. And that's it. Our assistant indent the sponge so we can tighten in the knot, and that's it. Right. And this is the results. If you like, I have another one, but maybe we are late.
I do one, then Vincenzo,
Yeah, okay.
and then I think we are in a schedule. So,
We can do many cases.
yes. My case now, again, opening of the conjunctiva. This takes some time, and you want to stay posterior to tenons, so you have a good view to do what you are doing there. And in this case, again, you will see that scleral thinning might be a problem. I'm used to opening just the quadrant where I place the buccal like you did. When I first started, we opened the conjunctiva everywhere, but that's not mandatory. So there you see the problem. And as in your case, the breaks are frequently in these areas where the wall recedes, where there's traction due to the receding wall. It's not vitreous shortening, but it's the wall that changes, you know. So then you, what's going on? So then you do the marking. There's a photo intraoperatively where you can see the break. There you, there you can see this round marking. In a second it will move, I think. It will not move. We make it move. So see, and that's the round mark that is left by the probe. And that's right there where the skinning is. And now take a good look at my first needle pass. So it will become better in a second. Trying to stay upstairs, and then, oops, upstairs again. So there I was too deep, you know. There's a perforation. It was in the detached retina. I had the luck of not having a retinal hemorrhage, and I didn't drain much. So the other one went better. But this is a little bit challenging, the thin sclera. And then for the cryo, this is a photo again of a cryo lesion of a horseshoe break. Then you suture the breaks, and of course then with the suture in the suture path, you will lose some subretinal fluid. But again, don't drain it completely, don't inject fluid or air or anything if possible, because the eye will tolerate it better. If it doesn't get, fortunately it didn't. This is the post-op photo of this break on the sponge, and then you close the conjunctiva. So if you have a hemorrhage, it's a different story. Then you have to pressurize the eye, and you have to move the eye away from the macula so that there's no subretinal hemorrhage. It will happen if you do enough cases, but again. Vincenzo.
Yeah, my case is nothing special. It's just a recall. The use can be. This is just a recall of our minimal surgery, which means. Given such a detachment with a single break or a couple of breaks just in 1 clock hour, remember the double patching this night before, and then the horn and ocular pressure, which is good for getting a soft eye. Have a soft eye at the beginning, it's good because then you have more space for your indentation. The moment you know that not to be too soft, just to avoid an choroidal, but then you open the conjunctiva just in correspondence of the two recti, because you open and make always the difference between conjunctiva and Tenon's capsule to separate them all the time. And use the silk in this case to hold the muscles. Then search for the break. Always, while searching, move always along the meridian. This is good to find the easier. So mark the pencil and mark the distance from the limbus, because then it's easy otherwise to forget it or to not find the break there. And then the longest path you can, as we have seen, stay always at 1.5 millimeters from the sponge, from the borders of the sponge. So for a 5 millimeter sponge, 8 millimeter of path, and then tie the sutures. And just after tightening it, you will I short it because otherwise it's a longer video for nothing. And then you tailor the sponge, because you don't need a much longer sponge in order not to move too much space inside for a short effect. Then check for the patency, for the positioning of the border of the buccal and the patency of the central artery, I would say. And always in this instance, ask always the anesthesiologist about the blood pressure, because for you it's important to know not to have low blood pressure in these patients leaving the OR, because the pressure in these eyes where you are not giving a drainage, the pressure in the eye can be high. So if you have a low systemic pressure, they can get some accidents, some vascular accidents when you don't use it. And that's all. I mean, that's the end of the suture. Again, first you suture the tenons, and then you suture the conjunctiva, and that's done. Who is now? Felipe? Or
Okay, thank you very much. Questions to this case? Again, short remark. Somewhat longer suture pass would even have been even better. Okay. Now, the last 10 minutes of this course we're going to spend with some cases we have done in the past, in the recent times, and where we want to have your cooperation. You please give us some ideas what we should do, and we start with some of these cases.
Yeah, start.
Dr. Cabrita from Portugal, please.
Yes.
Yeah.
I know it very well.
Hello, dear friends. So I would like to share with you the case of a retinal detachment in a 15-year-old horse rider. So this is a 15-year-old girl, horse rider, with a history of multiple falls and a history of 1 week vision loss in the left eye. She had a macular half superior temporal retinal detachment from 12 to 3 o'clock, and a retinal dialysis between 1 and 2 o'clock, and a visual acuity of 0.3. What would you be your first line treatment?
So, who would vote for A? Pars plana vitrectomy with tamponade. No hands. Sclerobuckle with drainage. Maybe long-standing maculas off. I see one hand. Sclerobuckling without drainage. We seem to have convinced a few people. And do nothing, just observe, treat with Kodachrome. It might go away by itself. Nobody. Okay, so C, what did you do? C.
Yes, I did a skull buckle without drainage, of course. Yeah, so our surgical approach was a segmental buckle applied from 1 to 2 o'clock. No subretinal fluid drainage was performed. We didn't do cryo because our probe was currently unavailable. And, and in the first postoperative day, the retina was fully attached and the best corrected visual acuity had already improved to 0.8. 1 week after the surgery, we applied 150 argon laser spots around the area of the retinal dialysis, and the best corrected visual acuity was already 1.0. Four years after the surgery, the uncorrected visual acuity remained 1.0. The retina remained completely attached, despite the patient continuing horseback riding and experiencing additional falls over the years.
Very nice case. One question. Do you induce some astigmatism with a sponge, and how does it change?
No, I didn't.
You didn't?
No,
Excellent.
no,
From
didn't.
the radial sponges, anybody, what's your experience with
From my experience is with radial, you won't have, you can have
1.5 in such cases. If you do a high indentation, you can have a 1.5, maximum 2 dioptries. But let's wait 1 month, because after 1 month, it's 0.5 doesn't fit, but only for circumferential.
Ingrid, one case. I think Harvey and you did a comparison of cryo versus post-op laser, right?
Yeah.
Is there a difference?
No. If you did enough cryo or laser around the tear, in particular horseshoe tear, important is the operculum, there's no difference. We could test it with a balloon. We removed the balloon afterwards, and a lesion is a lesion. You know what happens. If you do a mild cryo, medium lesion, you have a very hard and strong adhesion. And therefore, we tested it in animal experiments, follow up 3 years, 300 so many lesions. There's no difference. With cryo, it's predictable. With laser, we couldn't predict so much.
Stefan,
Second case?
That's your,
Starting the case?
yeah. That's your conclusion.
No,
He didn't finish yet. Yeah. So like the take-home message is a good buccal position can reattach retina without drainage. Avoiding drainage may reduce complications like retinal incarceration or hemorrhage. And in this case, total retinal reattachment was achieved without drainage with an excellent long-term results.
And I think, Thorsten, we can add here that you don't need, if your buckle is in proper position, you don't need immediate retinopexy. You can even have it staged a few days later. Another thing, as to the question of inducing a refractive error, encirclage, depending upon how tight, can go from minus 1.5, that is myopia of 1.5 diopter, to I've seen 6 diopters of myopia being induced with an encirclage. So it can be very tricky, especially for younger patients.
So we would like for the next case. The patient, a young lady, 17 years old. She was by the eye doctor. She had complaints 2 months ago. Blurred vision on the right side was by the eye doctor. Examination was unremarkable. She was there once more. Then he diagnosed a rhegmatogenous detachment on the right side. Myopic, myopia minus 11 on the right, minus 10 diopters on the left side. In the evening, the young lady came to our department. The father at this moment working in New York. He flew in the night to Austria because he wanted to support his daughter and called in New York, who is the best in the world, who will do the surgery because it's his daughter. Should he come from New York to Europe or should the daughter come to New York? And at the next day, we looked to the retina. It was not on the right eye, it was on both eyes, a retinal detachment. Subretinal fibrous reticular tissue like PVR formation. It must be an older retinal detachment, more than some few days. And we saw this on both sides. What to do as a next step? Where is the break and what to do?
Is there any particular general history?
Nothing.
Was she
No trauma.
No ROP?
No, we went nothing. No ROP. No. Nothing.
The high myope?
High myopic -10, -11. I called a colleague from me. He told me on the right side he will do vitrectomy, on the left side cerclage.
Yes. So this is not the best in the world.
What to do? We looked with contact lens. Should I inform you?
No, show of hands. So I would say on the right eye, I found a break at 7 o'clock. What would be my, could we go back one here? Yes, one back on the first slide. No, one more? Okay. So if you have those rules, I find a break at 7 o'clock.
There should be another one.
Yeah, so if I just close a break at 7 o'clock, what would be my chances of curing the detachment? 2%. So there must be another break. Huh?
Not very much.
No, shouldn't do that operation.
And what?
So we looked precisely. We used a contact lens for this young patient, the young lady, high myopic. We could find on the right side at 11 o'clock a horseshoe tear, and at 6 o'clock lattice degeneration with a break at the border of the lattice degeneration. Then we took the contact lens to the left eye in front of the father and the mother. And on the left eye, we also found a horseshoe tear at 1:30. And I was not sure at 3 to 4 o'clock if there was a break or not. At the moment, the girl collapsed. Yes. As you see here, that's not the break, but I was not able. I thought maybe there is a break, but the lady collapsed laying on the floor, and the parents, they were very angry about that fact.
But
and
she
I was
doesn't collapse during surgery. There you can find it.
Yes, that's very good. Professor Kreisig, we have a second chance. We can look during surgery. And this is what we had done. We have learned from you and the experts to also use the ophthalmoscope intraoperatively to look if there is a break or not. And what we did, of course, we have learned today, we did on the right eye a radial buckle at 11, a radial buckle also at this break at the border of the lattice, and on the left eye we made a circumferential buckle. I was not very sure if it was a break, but I supposed it may be a break, so I took the circumferential buckle to support. Yes, I did it. So I did the cryo here and also here, and we had 1 week later a residual detachment concave borders on this right side, and on the left side a residual detachment here. And the parents were not very happy because in OCT you saw the retina detached. And they looked at me and said, "You were not very successful, the retina is still detached." This was 1 week later. And if we look further, 5 months later, you see the retina on the right side, it's already attached, but on the left side, still detached. And in the OCT, the parents has something in their hand, a paper with the detached retina, looked at me, father and mother, and it doesn't look that they were very happy. The lady had visual acuity was 1.0 on both sides, but the parents were not happy, of course, because of this.
They had it black on white.
Yes.
Black on white, there's still detached.
How did it continue?
We finished, and 8 months later, also this part reabsorbed of the subretinal fluid. Thank you very much.
One question. If the questionable break at the right eye at 6 o'clock would have been in the lattice, would that have changed, or would you still have put it on a spot?
It would have changed because then buckle is not needed anymore.
That he learned.
Yeah, yeah. So most questionable breaks within lattice are no full thickness through breaks. At the edge of lattice, it's a different story, and I think that's why you did have to do that.
Now Gobani.
Now Gobani, okay. I will progress a little bit further because we have one special case we want. We have to discuss.
We have hidden it.
No, I thought we would have more time. Just a second. Here we go. This is a 70-year-old female, a wife. from Russia, a wife of a colleague, and she on Karfreitag in English.
No. We should say she's a wife of a colleague because I think we can be concrete, we're among us, because her husband had been in our teaching courses, and he was a smart husband of a wife with a detachment. Now you want to continue.
Yeah. Well, and she complained of a sexual visual loss. He examined her at home. He found this quadrant detachment.
Macula attached?
Macula attached at that time, but it was Karfreitag in English?
Good Friday.
Good Friday. So it was Good Friday. So I think they said, well, we have to go to the nearest university clinic. So he actually did see the break, and the break was up there. So in that clinic, there was the resident on call and the
vitrectomist.
Yeah, a vitrectomist, and said, well, I think we have to do major surgery. And the husband said, well, but as far as I know, we only need a sponge. Yes, you can do a sponge, but you never know. But if you insist on it, yeah, but the sponge can be done in local anesthesia. My wife has rheumatoid arthritis, has cardiac failure, and so on. Please, can we do it? Yeah, but if we have to do a sponge because you want it, then at least we have to do it under general. So that's what they did. They did the surgery right away. Sponge, cryo, drainage, intraocular air. And then on... No. Not that. And that's how it looked on Tuesday after Easter, when the chief of that department was up again. So it was more retina detached. There was macula off in between. And there's starfold, or at least some condensation. And I would say the break and the sponge had nothing in common. So what do we do now? So what was supposed?
No, the patient called me.
Well, actually, the chief said, okay, that's easy. 72-year-old failed sponge operation. We have to do a cataract operation, vitrectomy, and maybe we can get away without oil. That was the supposed operation for that Tuesday.
And then the person who was in our teaching course in Russia called me. What should I do? I said, two alternatives. Either where you are, close by, is a very good pupil of mine, Professor Böker, he was in Bonn, or come to Tübingen, we are ready to treat your wife. And then they selected what is the closest, even for a foreign country.
Yeah, but I was heading the retina department at that time. But I had a boss.
I had built up.
Yes, the one you did build up in the 70s. And but I had a boss, and I had to present this case before surgery, and said, well, I would just try to change the buckle, place it in the correct position. And he said, well, Thorsten, but if you're in any doubt, just put a band around it. It's so much safer. And so he let me do the surgery, and I just replaced the buckle where it belongs. I didn't place an encircling band, and fortunately...
It did not drain?
Did not drain. The retina reattached within a couple of days. There was some remaining residual fluid inferiorly with concave borders and surfaces that went away. So this lady kept her lens because she still had very good visual acuity. And... yeah, so is a sponge operation, as we have seen in the first case here, is it a bad operation, or if it's only a bad outcome if it's not done correctly? That's a question.
No, I would say the first operation was too dramatic. They did not find the break. I'm sure they did depress too much. They indented very much. They did the wrong cryo. They did too much cryo. They drained. Did they inject air?
Yeah, they did.
And how can you, I'd give you an advice how, or I would alert you not to do it. You can get PVR. If you drain, cellular erection, breakdown of blood FGS barrier. If you do cryo too much, you get a cellular erection, resulting in PVR. If you indent too much, cellular reaction, PVR. And what did we get? The hole was not treated, the detachment increased, of course, thou drained, and there was gas. What does gas? Reattaches the detached vitreous. You are just happy that the vitreous had detached and only made this one hole. You get Staufhold. So with other words, there everything was done to get the PVR. And you can avoid PVR. You don't need cortisone or other things or vitrectomy if you don't traumatize an eye. And I think this, at the end, a very good case you are presenting, Torsten, to tell you, you are able to induce PVR. It's not a bad eye. It's not a very, very good surgeon. It's not a difficult eye, it's a difficult surgeon who did the wrong thing, who induced PVR. Keep this in mind, keep out of the eye, don't drain, don't indent too much, don't overdo cryo, and don't inject air, which reattaches the vitreous membrane and causes cellular reaction, causes PVR. It was great to have you here. All of you get a diploma last night. Too late in the night, I signed all your diplomas. You might put in your name and no other name, because you had been here. And we are looking forward. I hope next year at eu-retina, I was informed, we have again such a course, if there are so many participating. And we are already in planning a teaching course in India, in Qatar, in other that's Middle America, even in Puerto Rico. So we keep contact. And whenever you have questions, write emails. We are answering. Have a nice home trip. Au revoir. Hasta la vista. Do svidania.